let me keep quiet. Oncology, radiology, oncology, match too.
Oh my God. That
Okay.
is
Is it
good.
Let's
Lamide
just
you are
say
talking about?
Who?
This person, Olamide Ajayi.
No. This one is my friend, Ijoma.
No, this one that okay. The first one, me, I know this first
Pediatric.
one. No.
oh
This
yeah,
one is
Dr. Olushola, let us start.
Dr. Lucia, give me her number now. Give me her contact.
The first one, I know her. We
That
went to the
Jai.
same room too.
Please, you guys will be
Olamide.
collecting content at the end of the class, so please.
Oh yeah, let's try.
Dr. Lucia, please don't forget to send me her contact. I
Dr.
beg.
Anthony,
I
I
don't want
bug Dr. Olushola,
Okay,
bombard him with
I'm
message.
not
He will send it. Don't worry.
Let's continue.
So,
okay.
today we're going to continue with mechanical ventilation. So, from what we have here, mechanical ventilation is just a process by which gas is moved to and from the lung by an external device, which is a mechanical ventilator machine, and it's just there to artificially support the function of the lung. So you can use this machine via two ways. It might be invasive or it may be invasive or non-invasive. So most of the time, the one we see is the invasive one, where you have to do a tracheostomy, particularly if you will need to keep that patient on a mechanical ventilator for more than 2 weeks. So you might need to go for a tracheostomy where you have to make a hole in the trachea, or you insert a tube into the trachea to gain access to the airway. Then the tube is connected to the mechanical ventilator. Sometimes we use non-invasive method to using a mask, but most of the time, particular patients are very bad that you need to control that airway so that they don't aspirate. You might not want to use a mask, so you prefer to go for the invasive method, which is through a tracheostomy for longer patient, maybe patient that have tumor in their brain and they are kept in the ICU. Definitely, you are not going to be using endotracheal tube. You have to do a tracheostomy for them, or endotracheal tube for ones that are not very prolonged. So, what are the general indications for invasive mechanical ventilation? Because that's going to be the focus of our discussion. So, it's just to know 3 major things. Then you had hemodynamic instability to it. 3 major things. We remember oxygenation, ventilation, and airway maintenance. That is all. Oxygenation, ventilation, and airway maintenance. So, and when we were discussing about abnormalities involving oxygen and CO2 parameters, there was one time we were talking about ways to correct it. So, for example, when we were talking about CO2 abnormalities like hypercapnia, we said the only way you can rescue that patient out of that hypercapnia is to hyperventilate that patient so that the person can take out CO2. So, anybody that has hypercapnia, and maybe the person has some problems with their respiratory mechanics, they cannot hyperventilate, and you need to help them, you have to use a machine. So there are so many stuff that can lead to problems with ventilation. That is, problems with you bringing in air and in and out of the lungs, bringing in air in and out of the lungs. For example, someone that has flare chest. So I don't know if we did it in our step 1, but I think we are going to talk a little bit about flare chest downwards, or anybody that has inadequate ventilation from any other thing, like maybe head trauma, maybe the person had a stroke, maybe the person was on some medication that dampened the respiratory drive. All these people, they will not be able to maintain that respiratory mechanism to breathe in, breathe out. And if somebody has problems with ventilation and the person is hypoventilating, what is going to happen at the end of the day is hypercapnia. Don't forget, the way we can differentiate between the 2 types of uh, normal AA gradient, do we remember, is to look at what parameter? Anybody remembers? The 2 causes of normal AA gradient. You want to differentiate between them. What parameter do you look at for?
PCO2.
PCO2.
So when you look at the PCO2, exactly. So when PCO2 is elevated, you know that definitely this person is hypoventilating. What is the cause of that hypoventilation? Is it that the signal from the brain is not there to control the respiratory muscles, like an individual with stroke, an individual with opioid poisoning, an individual with head trauma? Or there's a problem with the chest wall itself, the muscles, they are paralyzed, polio, myasthenia gravis. ALS, that or flare from trauma. Someone that has flare too, that respiratory mechanism too is impeded. The person will not be able to ventilate well. It will lead to hypercapnia, requiring a need for mechanical ventilation. So that's ventilation. The next one is to look at oxygenation. There are some abnormalities that lead to, very low oxygen level that you need to, mechanically ventilate that person to be able to drive air into that lungs. It's not as if the person cannot breathe. The person can breathe, but then air is not still getting into the lungs. So, for example, someone that has atelectasis, the problem is not ventilation. The person can breathe in, breathe out, but the lungs are collapsed. So you need to open it up. You need to introduce a positive pressure, from a machine to open it up. Or someone that has, let's say, COPD, for example. Remember, COPD that has failed the non-invasive trial. You need to mechanically ventilate that person. You create a positive pressure, to give that PEEP and allow escape of the gas at expiration. So that's the function of mechanical ventilation, helping in oxygenation. Because in COPD, you have that gas that is being trapped at the end of expiration. So you need to deliver an extrinsic PEEP to widen the airway so that those guys can escape. Or someone that has an oxygen can also come in for adequate oxygenation. Or maybe someone that has the airway collapsing, they have collapsed. It's not as if the person cannot breathe in, breathe out, but there's no part of the lungs to even receive the air that the person is taking in. So you need to introduce a positive pressure to open it up, and that's in situation of atelectasis. So all these conditions leading to hypoxemia, your mechanical ventilator can help you. Then lastly, it is not a problem with ventilation. It is not a problem with oxygenation, but it is a problem of maintaining airway. For example, someone that has a stroke, someone that has air trauma, someone that has just had a seizure, and it's very, very difficult, to control the glottis, to control the airway. You want to place them on mechanical ventilator because the mechanical ventilator tubes, which is the endotracheal tube that you have introduced into the trachea, it has a tube, that prevents movement of oropharyngeal content or even content from the stomach up, into the pharynx to enter into the airway. So they are kind of occluding the airway so that you don't have content from different part of the body like stomach or the oropharynx to enter into the airway. So you might protect them from aspiration by placing them on invasive mechanical ventilation. So don't forget 3 things to just remember: problem with oxygen, problem with ability to bring in air and out, like inspire, expire, inspire, expire. You can inspire, you can expire. So due to problems with the chest wall or the problem with the control from the brain, they will need mechanical ventilation. Or someone that doesn't have adequate control over their airway, you will need to do invasive mechanical ventilation to secure that airway. Then lastly, people with hemodynamic instability in some particular situation. It is not everybody that is in that has hemodynamic instability that will do um, mechanical ventilation. For example, this is an example: an individual with sepsis. Of course, the person is going to have a very low blood pressure, and sepsis is a commonest cause for severe ARDS. So if that happens, you need to take over that airway, mechanically ventilating that person. So this example now is like a mix of both hemodynamic instability and oxygenation in a way, if you look at it. So that's where hemodynamic instability can come in. So this is just like a small note for flare chest. So we're not really going to go into it detailed. I'm just going to give us an overview of what happens in flare chest. So flare chest is a situation where you have two or more, let's say two ribs, two adjacent ribs that fractures. So this can impair the respiratory mechanics of the chest wall when this happens. Normally, for inspiration to happen, you need to generate a negative intrathoracic pressure. How do you generate this pressure? The diaphragm contracts and moves downwards. the intercostal muscles also contract and they move the chest wall outwards. That should be the normal thing. Diaphragm contract, moves downwards. The intercostal muscles, they contract, they move the chest wall outwards. But remember, in flexures, there's a form of discontinuity because the ribs are broken. Those muscles don't have control over that particular ribs. So when the other ribs are moving outward during inspiration, they don't move outward. They move inward. They move inward. So you can use the word inspiration in. So that's a paradoxical movement. So during inspiration, when the other muscles, the chest wall itself, the other ribs that are still intact, they are moving outwards, generating a negative intrathoracic pressure so that you can accommodate the volume of air that is coming in inspiration. That doesn't happen for the broken ribs. They move inward. That inward movement of those broken ribs do not allow for creation of the adequate negative intrathoracic pressure to bring in air. So it's going to impair ventilation. It's going to impair ventilation at the end of the day. So that is flexure. So what do? You need to introduce a positive pressure, particularly during inspiration. You introduce a positive pressure to force out that fragmented rib that is moving inwards during inspiration, to bring it out. So I'll be able to expand the chest cavity, the lungs will be able to expand too, and they'll be able to receive air that is coming in during inspiration. So that's one of the problems in failed chest. Another problem is that people with flared chest, they have pain. That's why one of the things you want to ensure you take care of in people with this condition is adequate analgesia. Because that broken ribs causes severe pain for them that they find it very difficult to ventilate. They will not want to breathe because they know if they are trying to breathe, that exculpatory movement can bring about pain. So ventilation is kind of minimal in people with flared chest. Then they also have associated pulmonary contusion. So that also causes alveolar hemorrhage and bleeding, which also impedes oxygenation. So 3 things in people with flared chest, but that is just a summary of everything. The fact that the ribs are now moving in a paradoxical manner, the associated pulmonary contusion, and the pain. So the solution to the ventilation is to help take over the breathing by taking over the breathing and also delivering a positive intrathoracic pressure to force out that ribs that is moving inwards during inspiration so that they can move outwards and you can generate the right pressure to take in air into the lungs. So this is a curve showing the airway pressure and the phase of breathing. We know we have 2 phases, inspiration and expiration. So this stuff is not very, very complex. So I'm going to talk about one particular mode of mechanical ventilation. There are different modes, but we are only going to look at one, which is what we are required to know, and that is a volume control. I'm sorry, just a minute. I want to be sure. Yeah. Volume control. Okay, I thought I have it somewhere. Okay, I don't have it. Yeah. So volume control. So before we get to that, this is a curve showing the pressure within the airway and the phase of breathing. Now, we remember that the mechanical ventilator connected to an individual is more like a closed circuit. So you connect the endotracheal tube into the trachea. You put it, if let me see if I can make like a drawing. So if this is the trachea here, dividing into the main stem bronchi, your tube is going to come in like this and it's going to stop very close to the carina at this point. The reason why the tube has to stop at this point is that so that it doesn't enter one and you go and do endobronchial intubation. So anybody that intubates one bronchial, like this is endobronchial intubation, not endotracheal intubation. But if it is just at this tip here, stopping here, both of them will get hair and you can ventilate both lungs. If you intubate one bronchial, it has consequence, and we are going to see the consequence later as we move down. So let me just quickly explain what is happening here. So this is inspiration. This is when inspiration is starting. An individual takes in air during inspiration, or the machine delivers that tidal volume during inspiration, because in mechanical ventilation, you can the person can still control, but you can set it to a limit that the person should not take less than maybe 12 cycles per minute. So if the person takes less than 12, your machine will continue. The machine will continue for that person, so that person doesn't take less than that. So your mechanical ventilator has so many functions, but we cannot go into all those details right now. We just need to know the basis of this graph, the pathology I share with it, and we move. So at this point now, the mechanical ventilator triggers a breath. Normally, if this breath was triggered by an individual, you are going to have a negative deflection first before you have this sharp rise. It will look as if somebody has a Q wave, then a R wave, but you don't have this negative deflection. So it means that this breath was actually triggered by the mechanical ventilator. So the person takes in air enters during inspiration. And when air enters, air is going to exert pressure. So pressure increases, right? Then at expiration, the person brings out air. The pressure what? Decreases. There's like a latency period. It starts again. You know. Now, let me just say something before I continue. You see, this point to this point, to this peak, this point to this point, that is what we call the peak inspiratory pressure. That is the total pressure that you need from your mechanical ventilator to push in air and expand the lungs. To push in air and expand the lung, you need a peak inspiratory pressure. Now, there are some pressure that the mechanical ventilator will need to overcome before the mechanical ventilator can deliver air and expand the lung adequately. And there are three. The first one is the resistive pressure, this here. The second one is the elastic pressure. The third one is what you call the peak end expiratory pressure. So we'll look at them one by one. I want us to see restrictive pressure as a product of the circuit resistance and the airflow. That is the restrictive pressure. So I have it here. The circuit resistance and the airflow. So because the circuit has a form of resistance, inbuilt resistance. The narrower, the more the resistance. And also airflow. The fact that there's a flow of air, within a circuit, within an airway, there's a form of air resistance there. So no flow, no air resistance. With airflow, there's going to be air resistance that is going to contribute to the restrictive pressure. And also the caliber of the circuit too, can bring about the circuit resistance. So if you make the circuit narrow, you compress the endotracheal tube, or you compress the airway of that individual. I've said it is a closed circuit, so everything is connected to each other. Your endotracheal tube is connected to the machine. So air is being pushed from the mechanical ventilator down into the person's lung. It's not escaping anywhere. So if you kink any part of that machine or any part of the airway, it's going to affect the restrictive pressure. If you deliver air into the airway, it's going to affect the restrictive pressure because of airflow resistance. So it's very important we understand that fact. Airflow plus times circuit resistance bring about restrictive pressure. you need to overcome that pressure. So it has to be part of what you are going to be adding to make up your peak inspiratory pressure. You need to factor it that this mechanical ventilator where we want deliver air into these lungs. You get something when you go encounter. For example, if the air self the flow, pressure resistance go deal, or even the caliber of the vessel too. That circuit resistance can also, create a problem. So I have to account for it. Both of them, they no fit pass 100. Okay, I have to deliver 100. Now, extra thing to dey ahead. Extra stuff dey ahead again. Aside this residual pressure, there's something else. Elastic pressure. Elastic pressure is more like elastic recoil. So that is a function of the compliance of the lung. We know normally that the lungs have tendency to recoil on themselves and come inward, like they bring themselves inward together. Now, if you want to open that lung and you want to deliver pressure to open it, you have to overcome that that elastic recoil. So that is the elastic pressure. So it means the less the compliance, the more the elastic pressure, and the more the peak inspiratory pressure you need to deliver to open up that lungs. So elastic pressure is very, very straightforward. So elastic pressure is not only the function of the lung elastic recoil, but also the chest expansion too, because the chest wall also has its own elastic recoil. The chest wall undergoes elastic recoil in the outward direction, while the alveoli themselves they undergo their own elastic recoil in the inward direction. So you need to take care of both of them. Both of them contribute to the elastic pressure. Then the last one is the PEEP. So PEEP is just the pressure that is in the alveoli, that is keeping the alveoli from collapsing at the end of expiration. We know that a particular volume of air rather, remains in the lungs at the end of a normal tidal expiration. Who wants to remind us of that volume? At the end of a normal tidal expiration, what volume of air remains in the lungs? Anybody knows?
Volume, the residual volume.
At the end of a normal tidal.
Functional residual volume.
Functional residual
Yeah,
capacity.
so that is the functional residual capacity. So there's like a pressure in those alveoli that is preventing them from collapsing at the end of their normal breathing. They are still patent. They are still open. Because if you take out all your hair, everything will collapse. Bam! They will collapse now. So if you want to bring in, you have to open them first before. So it will be very, very difficult. So what is keeping them from collapsing patapata is our intrinsic PEEP. It is our intrinsic PEEP. Now, if you want to bring in air into the alveoli, you need to also overcome that PEEP in a way. You need to press it down. That I know you are opening the alveoli for me, but I'm actually stronger. I want to push in air into those open alveoli, because the PEEP is also going to be creating more like a resistance for you to bring in air. It's just there to just keep them open, but it can impede air from settling in a way. So you need to factor your PEEP too in calculation of for your inspiratory pressure. So the higher the PEEP, the more the inspiratory pressure you need to deliver air into those alveoli that are opened by your PEEP. So those are the three pressures: the restrictive pressure, the elastic pressure, and the PEEP. To also shed a little light on the PEEP, we remember that air moves from positive pressure to negative pressure. Now, let me give us an example. Let's say that the PEEP at the end of my first expiration is 0. Then second expiration is 5. Now, and we know that air moves from where pressure is greater to where it is smaller. Which one do we think is going to require more effort in terms of pressure to deliver air? When my PEEP is 0 and when my PEEP is 5. When my PEEP is 5, it means that there's a positive pressure of 5. When my PEEP is 0, it means you have, less pressure of 0. So, and let's say the gradient in the atmospheric pressure is like 10 millimeter of mercury. This is a very high gradient. So here can easily move in. I don't need much work. But here there's something like +5. So I need to work more to overcome this. I don't know if you get that, if you get the analogy. Because the gradient here is smaller than the gradient here. Do we understand what I'm saying? Hello, no feedback, no feedback. Do we understand? Hello?
Not really, Doc. Not
Okay,
really.
now let me give you another example. What I'm saying is, you know that during inspiration, you have to create a negative pressure so that you have a pressure gradient established so that air from the atmosphere is going to drive in air downward, because the one in the atmosphere is kind of greater than the one inside, because you have created a negative. The one in the atmosphere is 0. The one inside is negative. So it's going to move from 0 to negative because that's a gradient. 0 is more than negative. So the more negative the pressure inside, the higher the gradient and the more easy for air to move from outside to inside. Dr. Joy, do you understand that one?
Agreed. I agree with that one.
So
Yeah.
the same thing is happening here. If the PEEP, which is the pressure inside the airway, the alveoli at the end of the expiration, is 5, and another one is -5. Okay, let me use -5. Which one do you think is going to allow air to enter easily? Is it the -5 or the +5?
-5.
-5. So now what you are now saying here is that, okay, we have a PEEP already that is increased, like +5. So that means that this is going to create a problem. So that means that we have to actually factor this +5 in the extra amount of, inspiratory pressure I'm going to deliver. For example, let me say that when it is 0, I just deliver 10. I just deliver 10 of inspiratory pressure to bring in air. But when it's +5, you know that I have to factor this +5. You know that I have to add like +5 to this 10.
Like it will be like 15
To
or
get like
something.
15. So that I can, that is exactly what we are doing,
Okay.
here. Exactly. So your
Thank,
PEEP, the higher the PEEP, the more the pressure you are going to deliver to bring in
yeah,
here.
thank you.
So that is, sorry, this stuff is messy. Yeah, so let's now look at the graph. So that's just talking about the total or the peak inspiratory pressure. So let's look at the graph again. So you're taking here, this is the pressure that you need to overcome, rising. This is the total pressure in the lungs after we have taken in air. These are the total pressure. But you notice that the pressure will fall at expiration, and at the end of expiration they are going to be 0. Now at inspiration they are going to increase again. Now let me now stop at this portion. You see, there's something they call inspiratory hold maneuver. Inspiratory hold maneuver. And what you want to obtain from your inspiratory hold maneuver is what we call the plateau pressure. The plateau pressure is part of the peak inspiratory pressure, and I will explain. So what we are doing is that the person breathing, then you hold, not breathing out, you hold it. Now, when you hold that breathing, you are no longer delivering any tidal volume again. No air is coming in again. The respiratory pressure is going to be eliminated. Because you remember, we said respiratory pressure is dependent on air flow, right? Because you remember, when you are taking in air, are you changing the diameter of the tube? So
No,
you are not touching diameter, but airflow, is still there when you are taking in air. Airflow is there, but you can control that airflow by seizing your inspiration. You are holding your breath. So that means once you hold your breath, you are not changing diameter, you are not bringing in air again. Respiratory pressure is eliminated. So when you take in air, and it rises, and you stop at this portion. This is where you do your inspiratory hold. What will happen is that the pressure in the airway at that point will equilibrate, and it will play through. Meaning that the meaning of this equilibration is that the pressure coming from the mechanical ventilator and the airway, the one in the airway at that point, they will kind of equilibrate to a particular level, and at that point they will stop. So it's going to reduce, and it will now play through. Once you stop breathing, it will reduce, then it will now play through at a point. Now, at that point, your restrictive pressure is out. So your restrictive pressure, what your restrictive pressure will now be is from here to this point. So this area only is accounting for your restrictive pressure. What is going to be remaining, is going to be your elastic pressure and your PEEP. So from here to here is going to be your elastic pressure and your PEEP. Because you remember, three things makes up the peak inspiratory pressure: your restrictive pressure from here to here, and your we have summed it up here. So, and your elastic pressure. Okay, no, we didn't sum it up. Let me upload this thing again. So from here to here, the restrictive pressure. From here to here, the elastic pressure and the PEEP. So actually, you are not starting from zero. This is zero. They are starting from here because this is the value of the PEEP. The PEEP is always there, baseline, to keep the alveoli open. So the PEEP, which is at this point, your elastic pressure and your restrictive pressure. That is the total for your airway pressure, which is your peak inspiratory pressure you are delivering. So the pressure in the airway where you eliminate breathing at this point is only going to be your elastic pressure from here to here. But at this point to this point, you have not eliminated what's it called? Inspiration at that point, because this is where you stopped breathing. So, and this is when you are now eliminating that restrictive pressure. So it means from here to here is going to be your restrictive pressure, because this is where the pressure is now equalizing. So here to here is your restrictive pressure. But because at this point it has plateaued, the restrictive pressure is no longer contributing at this point. So what is remaining in the airway or the alveoli, that is now, the pressure that the peak inspiratory pressure needs to overcome, is going to be your elastic pressure from here to here. I don't know if what I'm saying, if it makes sense to us in a way. I don't know. The stuff can be very, very confusing. But
So what you're saying is at the inspiratory hold maneuver, the
yes,
resistive pressure is eliminated, and
yes,
it's only you only have the elastic pressure and the PEEP. That's the summary of it all.
exactly. And your restrictive pressure is the one that is up from here to here, from here to here. That's your restrictive pressure, because at this point, this is where you stopped the inspiration, and once you stop breathing in, restrictive pressure is out. Now, that maneuver, you do it to obtain your plateau pressure. Plateau pressure is the sum of elastic pressure and the PEEP. So we can definitely now say that peak inspiratory pressure is the sum of plateau pressure and restrictive pressure. Dr. Antonio, do you agree with me? Because
Sorry, said
Yeah, exactly.
pressure will not be.
I said that once you eliminate inspiration and you have delivered your tidal volume, what is going to remain is elastic pressure and the PEEP.
And
So elastic pressure and the PEEP, the sum of that is our plateau pressure. Plateau pressure. Now, I now say that peak inspiratory pressure is the sum of plateau pressure and restrictive pressure. True or false?
True.
True.
Because you're removing both of them together is the plateau. So plateau plus restrictive will give us the peak.
Exactly. So what is up is restrictive pressure, and it is dependent on the airway resistance. What is down is elastic pressure, and it is dependent on pressure from lung compliance. So these are our PEEP at baseline. because from here to here is the value of the PEEP, maybe 5, maybe anything. That's the pressure at the baseline. So this is auto PEEP, and I'm going to explain what auto PEEP means. So to get auto PEEP, what we do is that, okay, you now try to breathe out totally. At this point, this is where they stop breathing. Now you now hold it. You know that normally, okay, now let me explain what auto PEEP means. Auto PEEP means that, for example, someone that has COPD, they are the ones that experience auto PEEP, if there's a word like that, because air is trapped at expiration. So you are adding more to the PEEP that should be there, because those gases that are trapped, they will be delivering intrinsic PEEP. Because normally you are supposed to take out a certain volume and remain a certain volume. So that certain volume will be exerting the normal PEEP. But when you have incomplete, emptying of the airway during expiration, you have a lot of gas that is trapped, and they are going to deliver a lot of PEEP. So that is auto PEEP. And you can actually know your auto PEEP at the end of expiration. So when you bring that to the normal, like you breathe out normally, you don't expect any gas to be there aside your normal PEEP. But if there's airway obstruction at expiration, like in COPD or asthma, you have more air that are retained, and they are going to exert extra PEEP. So that extra PEEP is what you call the auto PEEP. So in someone that has normal healthy lung now, after your expiration and you hold it, if you try to check for the auto PEEP, it will be the normal PEEP, which is this baseline. So this curve is not going to rise. It will fall on this line, because what you have is going to be the normal intrinsic PEEP. But in someone that has COPD, extra air is being trapped. So you now notice that this pressure is going to rise at the end of your expiration. When you hold it, you notice that it's going to rise. And that difference in your normal baseline PEEP to the peak of that curve is telling you the extra amount of PEEP that has been added, which is your auto PEEP. Do we understand?
Yes.
So let us look at the definition.
Dr. Babal, I'm having problem with the restrictive lung compression word. I didn't quite get that.
The restrictive is due to
restrictive pressure or something.
The restrictive pressure, okay. The restrictive pressure is just due to airway resistance. Like when there is flow across the airway, there's a form of airway resistance that kind of impedes, that kind of generates a pressure that influences the passage of gas. So what they are just trying to say that flow generates pressure. If there's no flow across the chamber, the pressure there will be low. Restrictive pressure there will be low. But once there's a flow, there's going to be a chamber pressure. Here we are saying airway pressure because the chamber where the gas is flowing through is the airway. And when that flow occurs, it's going to generate that air resistance. I don't know if you get what I'm saying. It's like physics. Flow of gas across a container or a chamber, they exert some pressure.
Okay.
So
is that that pressure makes up the resistive pressure of the airway?
Yes, it makes up the resistive pressure. But because the fact that the diameter can also affect the resistive pressure, but you know that the diameter is constant throughout. You are not changing the diameter. So it's going to be constant, but it also affects the resistive pressure. If you do something to that diameter now and you narrow it, you kind of kink it, or you just reduce the diameter, your resistive pressure is going to increase.
Yes.
So two things affect the resistive pressure: flow and the circuit diameter. The flow.
So and the diameter.
Yes, that is it. The flow and the diameter. So the only way you can remove resistive pressure is just because you don't have any control over the diameter. Diameter is diameter. Stop airflow. So there's nothing that is flowing through that chamber again. Your resistive pressure is going to be reduced.
Okay.
So that is that about resistive pressure. Airflow. Airflow. Look at it here. Reflect resistance to airflow. Reflect resistance to airflow. So if there's no flow, your resistive pressure is not there. But once there's
Okay.
flow, there's resistive pressure.
Okay.
So that's why you can calculate your Plateau pressure, which is the difference between peak inspiratory pressure and resistive pressure by inspiratory hold. So
Dr. Babale, are you now saying people with high restrictive pressure are
okay.
people that like restrictive lung disease, right? Or something that is obstructing their
No, I get where you are coming, Dr. Olorati. You see, if you say that people with restrictive lung disease, they are going to have problem with compliance. So their own pressure that is going to be increased is elastic pressure, and that is going to
Okay.
affect Plateau pressure. Somebody that can have problem with restrictive pressure is somebody, you know, I said diameter or narrow is becoming narrow. What do we think? What lung pathology can we think? Narrow diameter, anybody? If the diameter of
It
the airway is getting narrow.
things like asthma, something that constricts.
Yes!
Yeah.
Things like asthma, COPD, they will
Oh,
increase restrictive pressure. That is it. Asthma, COPD will increase restrictive pressure. So, or maybe the endotracheal tube, it kinks. Kinking of the endotracheal tube, it will increase restrictive pressure. You know, that is it. We are going to look at those pathology, but I'm happy that we are understanding even before we get to the pathology. So, we have talked about the peak inspiratory pressure, the three things it contains. The Plateau pressure, we already know the Plateau pressure. Plateau pressure is just peak inspiratory minus restrictive. So Plateau is elastic plus PEEP, and it talks more about the lung compliance. So the higher, because we already know that Plateau is what's it called? Elastic pressure plus PEEP. So it means that the lower the compliance, the more the elastic pressure, the more the Plateau pressure. Does that make sense to us? Elastic pressure is the pressure that is exerted when the lung chamber have high tendency to come together, to collapse, to come together, to collapse. And that tendency is increased in restrictive lung disease. They have high tendency to recoil, to collapse. Hope we agree with me that the compliance in restrictive lung disease is very small, right? They cannot stretch. So that means that they
Yeah.
have high tendency to come together as elastic fiber. And that means that their elastic pressure is very, very high. So that means that their Plateau pressure is going to be high. So it means that the lesser the compliance, the more the elastic pressure, the more the Plateau pressure. So that is why Plateau pressure is inversely proportional to compliance. Can we see that? Hello?
Yes, I understand you. Understand.
Okay.
So the higher the elastic pressure, the lower the compliance of the lung, and then the higher the peak pressure, the Plateau pressure.
Yeah.
That's what it. Okay.
Let me give one more example before I leave, because I'm not convinced that we understand. Look at a fibrous lung. A fibrous lung, if you pour water into a fibrous lung, it will not be able to stretch to accommodate that water. It means that it is not compliant. So in a way, it means that it actually wants to be in a shrunken collapse state. And that is a property of a chamber that is highly elastic. They want to come together, like shrink. Elastic pressure is very high. They want to come together. Elastic pressure means coming together. Elastic, they come together. Please don't look at elastic as stretching. No. Elastic is when you stretch something and that something has high tendency to return back to its original state, that is when you say it is very, very elastic. So they have a tendency to come back and collapse on themselves. Bam! So it means that if something is less compliant, it means that it has a very high elastic recoil, high elastic pressure, high plateau pressure. So, and don't forget, you use your end inspiratory hold maneuver to get your plateau pressure because you will have eliminated your restrictive pressure. The restrictive pressure is resistance to airflow. Airflow creates restrictive pressure and also the diameter of the chamber. So if you alter the diameter of the chamber, you can affect the restrictive pressure either by kinking the endotracheal tube or by mucus plugging of the airway or by narrowing of the airway, either by maybe asthma or COPD from the inflammatory stuff. Then the peak end expiratory pressure. So that's the pressure at the end of expiration. So this statement is very wrong. Normally equals atmospheric. There's something more they want to add to this statement. The PEEP end expiratory pressure is not equal to the atmospheric pressure. You guys can verify online. Like I hardly talk about books making mistakes, but there are some little mistakes in this step 2 FA, and this is one. The PEEP is always some pressure above the atmospheric pressure, and that is what is keeping the airway patent and not collapsed. You can verify online. So whatever we see, you can just let me know. If anybody sees anything contrary, we can talk about it.
Sorry, Dr. Bawale. What we're saying is that the peak end expiratory pressure is not the same is not equal to the atmospheric pressure,
exactly.
Right?
That's exactly what I'm saying. So
All
it's
right.
always above the atmospheric pressure. It makes sense because that is the pressure that is keeping the alveoli open. It's not equal to atmospheric. Atmospheric pressure is like 0. We put it at 0. So we measure all the pressure in the lungs in reference to the atmospheric pressure. So when we are saying it's 0, we don't mean literally that it's 0. We are just saying it as a reference that with respect to this, it is 0. So it means that, let's say that atmospheric pressure is 760 and the pressure inside the lung is 780. The difference is 20. So we can also say, in other words, so that we will not be recording large volume or pressure by saying that, okay, the one in the atmosphere is 760, we know. The one inside is 780. Why not say that the one in the atmosphere is 0 and the one inside is 20? We are saying the same thing. So that is it. So we say it in reference to 0. This one, most of the time, you put a level of like 5. It's always some pressure ahead of the atmospheric pressure. So, when there's incomplete emptying of air, just like I said, there's going to be an intrinsic PEEP, intrinsic positive end expiratory pressure that's going to be adding to that original PEEP, leading to auto PEEP. So auto PEEP can be measured in passive patient through an end expiratory hold maneuver. So at the end of expiration, you hold it, then you measure the pressure in the airway. So if you are expecting 5 normally and you get 10, you know that your PEEP that you are adding extra is going to be 5. So 5 plus 5 is what is causing the 10. So that is auto PEEP. So sometimes you can also deliver your PEEP, by using your ventilator, particularly in situations you want to prevent airway collapse, like someone that has ARDS, that surfactants are finished. You don't want the lungs to collapse. So you have to place the person on a positive PEEP to prevent airway collapse. Elastic pressure yes, Dr.
So this PEEP now, so what you're saying is at the end of normal inspiration, you have the intrinsic PEEP. Yes. But when you have auto PEEP is when you have like additional air trapping in the airway. So that's when you get auto PEEP. And it can be calculated by and the hold maneuver.
Exactly.
Okay. Sorry. So it kind of reflects air trapping.
Yes, it reflects air trapping. That's correct. So elastic pressure, also known as driving pressure. So that's the one that you need to expand the lungs. So it means that the lung that is not expansile or expansive, it has low compliance. The elastic pressure is going to be high. So look at it, due to the elastic recoil of the lungs and the chest wall and to the volume of gas delivered. So, the higher the elastic recoil of the chest wall and the lungs, the more, the elastic pressure, and the more the amount of peak inspiratory pressure you need to deliver to open or to drive in air into that lungs. And don't forget, elastic pressure is a part of component of the Plato pressure. We said it, right? That Plato equals, what's the formula for Plato pressure? Anybody wants to remind us?
It's
Elastic
elastic
pressure
pressure
plus
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 PEEP.
PEEP.
So that means that once we know Plato pressure and PEEP, we can calculate elastic. So elastic equals Plato minus PEEP, Stephanie. So that means that if I want to know somebody's elastic pressure, I don't need to stress myself. I'll just tell the person to breathe in, do and the inspiratory hold. I get my Plato pressure from there and I remove it from the PEEP. That is it. You already know the PEEP that you have set by your mechanical ventilator. So then you remove it. That's going to be your elastic pressure. So you can get it from the graph by looking at it from here to here. This baseline is your PEEP. So from here to here is going to be your elastic pressure. From here to here is your restrictive pressure. The total of everything is your airway pressure, which is our peak inspiratory pressure. So elastic pressure is increased in increased lung stiffness. Of course, restrictive lung disease, pulmonary fibrosis. The lung is stiff. Elastic recoil is high. Elastic pressure is high. Plato pressure is high, but compliance is low. Compliance is low. Reduced chest, expansion, reduced chest movement, reduced diaphragmatic movement can also cause an increase in the elastic pressure. For example, someone with obesity or ascites, they cannot allow air to come in. So you need to take in more pressure to force out that chest wall to move outwards so that you can bring in air. Because of the reduced chest expansion from anything, maybe there's kyphoscoliosis or there's obesity that is preventing the diaphragm to move downwards. There's ascites that is preventing the diaphragm to move downwards to create that negative intrathoracic pressure so that you can bring in air. So that the chest wall will kind of be compliant to expand to bring in air. It can cause problem with the elastic pressure. So the lesser the ability for the chest wall to expand or the diaphragm to move downward so that you can generate negative intrathoracic pressure to bring in air, during inspiration, they are going to cause problem with the elastic pressure. So just look at it as restrictive disease pathology. That's a simple way so that you don't get confused. Elastic pressure is more like problem with compliance. The less the compliance, the more the elastic pressure. And if you cannot expand the chest, it means that the compliance is reduced. That's what it means. So you can see that in situation of obesity where the fat have infiltrated all the bones, the muscles, and the stuff cannot even, the muscles cannot contract adequately so that they can expand the chest wall. Or the diaphragm that is supposed to move downward in ascites is not moving downwards. So there's no way you can generate negative intrathoracic pressure to even expand the chest cavity. So, all of them will have high elastic pressure. So let us look at pathologies now.
But how do the volume of gas, how does that one also affect compliance? Because I know, yes, you mentioned the elastic recoil, whereby cases of fibrosis, and you mentioned what's it called, chest wall.
Okay.
Using example of things like obesity and ascites. So for the volume of the and then I think they spoke about
Yeah.
the
So let's look
volume
at
of
it together. Let's look at it together. Do you remember what I said about tidal volume? What does tidal volume do to the elastic pressure? I said it. There was one time I said it.
It will increase it.
It will increase it. That is
not
it. So the more volume you deliver, the more it will kind of stretch the lung and increase the elastic pressure. So that is it. So the more volume delivered, the more the elastic pressure. That is it. That's why you want to avoid increasing tidal volume in people with restrictive lung disease. It's not going to help them. So, Dr. Antonia, what are you going to do if you want to improve ventilation and reduce work of breathing in someone with restrictive lung disease? What are you going to do to the parameters of ventilation?
You reduce tidal volume and increase the respiratory rate.
Solved. That is it. So, Dr. Lorati, so the more the volume of gas delivered, the more the elastic pressure. So, but the reason why we are not talking about it in pathology is that, do we have any pathology that we are going to be delivering more tidal volume? That is a pathology that we can only deliver more tidal volume maybe from our own iatrogenic issue, maybe from mechanical ventilation. That's why maybe it's not been mentioned. But it's good that at least you called our attention to it. So looking at the waveforms, let's look at the first one. This is talking about the peak.
Dr. Sorry, can you increase your screen? Yes.
This. Okay.
Yes.
Now, this, I think the blue one is the normal, right? The red one is the change. So the plateau pressure, did it change here? Can we say the plateau pressure change? Anybody? Do you have a change in the plateau pressure for what we are seeing?
I think it's the same thing.
It's the same
pressure
thing.
is
This is the plateau pressure from year to year.
Yeah.
So it is the same. But there's an increase in the peak, inspiratory pressure.
Yeah.
So it has increased by this value. Now, we know that plateau pressure is not affected by one particular pressure. That pressure is what? Restrictive pressure. So it means that for this person's peak inspiratory pressure to have increased and the plateau pressure was normal, it means that this person has done something to increase the restrictive pressure. And what are those things that can affect restrictive pressure? When you alter the diameter.
No, the flow and the diameter.
The flow and the diameter. The flow and the diameter. So, for the diameter, let's say there's kinking of the endotracheal tube. There's kinking of the endotracheal tube. Mucus plug occluding the endotracheal tube is going to reduce the diameter of the airway. Bronchospasm is going to reduce the diameter of the airway. Endotracheal tube is going to reduce the diameter of the airway. So, once there's a reduction in the diameter of the airway, it's going to affect the restrictive pressure, either by kinking of the endotracheal tube, or you use a tube that is very narrow, or there's bronchospasm, maybe from asthma or mucus plug, and there are different ways you can treat them. So people with kink endotracheal, you remove it and untangle. People with mucus plug, you suction out that mucus, so that it doesn't occlude the airway again and narrow the diameter. People with bronchospasm, asthma, you give them bronchodilator. Narrow it to you use the appropriate size endotracheal tube. So once you see any of these in your question stem, you know that they are definitely going to cause problem with the restrictive pressure, causing an increase in the PIP, but it will not affect plateau pressure. So look at it here. Increased airway resistance, but normal lung compliance. So think of anything that increases airway resistance with restrictive pressure increase. Decreased. Okay, now we have another situation now. Here, the plateau pressure has increased. Don't forget, everything will always affect the PEEP, because PEEP is the sum of everything. So you always notice increase in the PEEP. This is normal. So what might not change will just be the plateau. So here, plateau has changed. Plateau has increased. So what, will be responsible for this? Plateau have increased here. So definitely it means that elastic pressure is affected, right? Elastic pressure is affected. So that means that the compliance, elastic pressure has increased and compliance has reduced. So what are those things that can cause reduction in compliance? That's the thing to now think of. There are so many things. The ones that are very easy. Okay, for example, pneumonia. When there's pneumonia, there's consolidation, there's fluid inflammatory exudate in the lungs, not making the lungs expand very well. when there is pneumothorax, there is air within the pleural cavity surrounding the lungs, and they can keep compressing. Because if you look at the pleural cavity, it's like 2 layers with fluid surrounding the lungs. So there is the lungs. This is the lung. What's happening? Oh, I think I can't write on this. Can't do anything on this. Yeah. So this is the lung. Let's say that this is the parietal, this is viscera, and that is the parietal. So in between, this is the pleural cavity. Let's assume that we have air like this, like this. This air will be compressing on this lung at the end of the day. And when they compress, they are going to shrink that lung, and they are going to limit the expansion of the lungs. So that's going to reduce the compliance of the lungs. ARDS, you already know that already. So there's washout of surfactant, surface tension, increasing surface tension due to the loss of surfactant. Surface tension is more like elastic recoil. It's going to cause them to come inwards, and they are not coming outwards. Pulmonary edema, fluid there, they cannot expand because of too much fluid. Atelectasis, it has even collapsed. Compliance here is 0. Elastic recoil here is like 100%. It has collapsed already. Now, I want us to look at main stem intubation as atelectasis. Let me give us what I'm saying. Now, main stem intubation means you are intubating a particular bronchial stem. Either you are intubating the right or you are intubating the left. You are not actually putting it at the carina where the trachea bifurcates. So it means that all the volume of air that we are delivering is going to one lung and it's not going to the other one. What do we think is going to happen to the compliance of the other one that we are not delivering oxygen to? Is it going to look as if the compliance of the whole lung system is increased or it is decreased? Because you are not
It will
delivering.
be decreased.
Yes.
Decreased.
Yes, because you are not delivering air to it, you are not stretching it. So it will look as if the compliance of the whole lung system is decreasing. So particularly for that particular lung, So what you can do is to bring up retract that tube and place it at the central part of the bifurcation. Atelectasis, depending on the cause, we have 4 different types of atelectasis, I think. We have the obstructive. There's a foreign body or mucus obstructing airflow of air into the lungs, into the downstream alveoli. So when air cannot get into the downstream alveoli, they will collapse. At the end of the day, that's what happens. They will collapse. That's obstructive. Another one is compressive. If somebody has a pneumothorax can compress on the lung, just like I've explained. They will compress it and they can make it collapse at the end of the day. Another one is cicatrization. That's scarring. Someone that has pulmonary fibrosis, the lungs can get fibrotic to an extent that they will become collapsed because it will get so shrunken and to collapse at the end of the day. Then the last one is adhesive. Adhesive is the situation of neonatal respiratory distress syndrome that they don't have surfactant. When you have surfactant, surface tension is going to be high and it's going to draw the lung towards themselves and they will collapse. Bam! So depending on the type of the atelectasis, that is going to tell you what you are going to do. So if it's obstructive, maybe from mucus, cystic fibrosis, chest percussion, bronchiectasis, you try to percuss, expel that mucus. If it's foreign body, you do your bronchoscopy to remove it. Of course, cicatrization, you are not going to do anything. There's nothing you can do. Maybe you can just give antifibrotic, but it's not going to do anything. It's not going to do much. But for the what's the last one itself? The
cicatrization, the pulmonary fibrosis, right?
Yes,
Adhesive
cicatrization.
and
Adhesive. So you're going to give surfactant.
Mhm.
Then pulmonary edema will give diuretics, take out the fluid. ARDS, you are going to minimize the tidal volume that you can place on high PEEP so that you can open up those airway, a ventilation strategy. Please don't let us forget permissive hypercapnia, the ventilation strategy. Then Pneumothorax, you do your needle decompression immediately. Pneumonia, you give your antibiotics, and you're going to wait for a resolution of the inflammatory process, because you should not go more than a week or two. It's going to resolve. So that's that about the pathology. And let me quickly see if we can quickly look at the question, so that we'll be sure that we understand, because I want us to I want to be sure that we get
Dr. Babawale, when you were talking about the first one, I think that's the increased resistive airway pressure. That
yes,
one that you have the high peak pressure, and then that you have the normal, what do you call it now, the platelet pressure.
yes,
Why is it that under I was looking at it when you were showing it, we spoke about when you have like a kinked endotracheal tube,
yes, Dr.
as part of, what actually causes it. But I was also looking at it when you were talking about bronchospasm. Is the bronchodilate that they are putting there, is that a treatment or what?
Yes,
And the use of
bronchodilation is a
narrow,
treatment.
okay,
Bronchodilation is a treatment.
okay, and then the use of narrow endotracheal tube,
Tube
right?
is a problem, is a cause. So
Is it that
yes,
was what
yes,
confused me.
yes,
Okay, so the first one is like a management measurement, and then the second one is like a cost, right?
yes, exactly.
Okay.
So kinked endotracheal tube is a cause. Mucus plugging is a cause. Bronchospasm is a cause. Narrow endotracheal tube is a cause. So
Okay.
okay, so let us look at this question. A 40-year-old man is intubated and receiving mechanical ventilation after being found unresponsive on the floor of his apartment. The patient is sedated and initiates no spontaneous breath. The ventilator triggers 14 breaths per minute. That's what it delivers, each delivering 500 ml of tidal volume. Because of difficulty in ventilating the patient's airway, an inspiratory hold maneuver is performed to further evaluate his respiratory mechanics. Because they are experiencing difficulty in ventilating, what is the problem? So they want to evaluate. They did inspiratory hold maneuver. During this maneuver, the ventilator is paused for 2 seconds after the entire tidal volume is delivered. The pressure at the mouthpiece measured when there is no flow is found to be elevated. Who knows what that pressure is?
That's your auto.
No, wait, Dr. Dorothy. Let me come again with the reading. The pressure at the mouthpiece measured when there is no flow is found to be elevated. The pressure when there is no flow, we have eliminated flow. So what's going to be the pressure that is remaining?
The airway diameter, is it?
When there is no
We
flow,
have,
there is no resistance. So basically, what would be left will be the end inspiratory, isn't it?
no, like, what pressure did we say we are going to measure when we do inspiratory hold?
That's the plateau.
Is it not the PEEP
The
that
resistive pressure.
we're talking about the
Plateau pressure.
restrictive pressure here?
Plateau pressure.
Plateau pressure is what will be measured, because with breath hold you remove the resistive pressure.
Exactly.
And what's the component of the plateau pressure?
We elastic pressure and PEEP.
And PEEP.
That is it. So they now said the pressure at the mouthpiece measured when there is no flow is found to be elevated. Please, what is elevated?
Either one of
the plateau pressure.
Is
and we know that when plateau pressure, because we know the amount of PEEP that we're actually delivering. So PEEP is out. So
14. Oh.
No, they didn't give us. So it has been set to. But we know that something influences the plateau pressure. Plateau pressure is a function of something. What is it? What does the plateau pressure suggest? Like, what determines the plateau pressure? What phenomenon?
Is it how compliant your lung is?
Compliance.
How compliant your lung is?
Exactly. So they said
Mm.
the pressure at the mouthpiece increase, and so that's the plateau pressure. So they now said the measure pressure most likely reflect which of the following. What was the answer?
Uh,
It
the
should be
compliance.
respiratory system compliance.
Exactly.
Yes. Okay.
Well, I see how to be guiding us, guiding us, guiding us. Well, I know this is the first time. So
We just it is this mouthpiece pressure at what which mouthpiece? Is that the patient's mouth or the ventilator?
yes, you know, don't mind them. They are just saying the pressure at like the airway that is remaining. That's just, the tube is at the mouth. So I think the pressure reading too, is going to be talking about the pressure at the mouth, the airway, everything is in equilibrium. So, that should not be a problem. But they just said the pressure at the mouth is measured and there is no flow. You already know that they have eliminated restrictive pressure. So what is left is our what was it called?
Okay.
Uh Plateau
Pulmonary.
pressure. So
Mm.
I just wish I can find another question, but this is the only question that I could get, but I'm sure we understand it, Sha. Like, looking at the graph, just identify where's the problem. Hmm? Just look at it. Once you see that plateau is normal, you know that okay, elastic pressure is okay. So the only thing that can increase the PEEP in that situation is restrictive pressure. So you check, is there a problem with the airway resistance? Is it that the diameter is reduced? Or you look at the plateau pressure. Plateau pressure is increased though. And we can only get the plateau pressure after we have done our inspiratory hold maneuver. So what's not making it increased? There's something wrong with the compliance. Why is it not compliant? Is it that there's pulmonary edema, ARDS, pneumothorax, pneumonia, all of that?
Fibrosis or something.
So ventilation setting. Oh, this is what I was looking for. So initial setting for volume or assist control. So assist control, volume assist or control is a form of mode of the ventilator. So what happens in this mode is that you have set the amount of tidal volume that is going to go into that lungs, 500. So what they will now do is that they will be recording the change in pressure of that mechanical ventilator. Once they notice that the pressure sensor has gone up, they will know that there's problem with the compliance or there's some problem with the airway. Let's go and check what is happening. That is volume control. So once the pressure goes beyond normal, the ventilator will make a sound and the nurse will respond. That's volume control. We have pressure control. In pressure control, what you are doing is that you are not controlling the volume that is going to go. You already have a fixed pressure. You are just noting the change in volume. We should not forget that compliance is compliance is change in volume over change in pressure. So if I want to know if something has gone wrong, what I'll just do is that um okay, for this mechanical ventilator, I set a fixed tidal volume. Oh yeah, be delivering 500 mil with each breath, 500. So if something happens along the way, and maybe there's pneumothorax that develops suddenly, bam. If pneumothorax develops, definitely the plateau pressure is going to increase. And when the plateau pressure, when pneumothorax develops, the compliance is going to fall. And that falling of this compliance is going to make this pressure increase. You know that I've already set the volume, so I don't expect the volume to be changing. I have fixed it to 400, 500, be delivering 500, be delivering 500. But something happens suddenly in the person, pneumothorax. Pneumothorax happen, the lung is no longer compliant, the pressure will now start increasing. So it can increase more than normal, and the machine will detect it and will ring a bell. Bam! The nurse will now run. What is happening to this patient? They will now look at the part of the pressure that's affected. For the sake of for the case of what's it called, pneumothorax, we definitely know that it's going to be the plateau pressure that is going to be elevated. So you now investigate along that line. That's how the mechanical ventilator works. So so there are some settings you can do depending on the pathology you are working with. for tidal volume, that's the first component. You want to set your tidal volume to 6 to 8. This is one of the high value. Like this is normal, actually, kind of high normal, 6 to 8. It can go to like 6. It can go to 8. But in some people, you might want to keep it low to like 6. Now, for people with obstructive lung disease, what you need to do for people with obstructive lung disease is that their problem is that they cannot take it out air completely during expiration. So what you want to do is that you want to prolong the phase of expiration. And the way you can prolong their phase of expiration is by slowing down respiratory rate. Instead of you do, no, just do, keep it to like 8 cycles per minute instead of 20 cycles per minute. So they have more time to spend in expiration and take out their air. And at the same time, you don't want to compromise ventilation by reducing respiratory rate. So it means that you have to bring up tidal volume, because you remember that ventilation is a product of tidal volume times respiratory rate. So as you are dropping respiratory rate for them, you increase their tidal volume. That's the pattern you do in obstructive lung disease. Reverse is what you do in restrictive. Restrictive lung disease because tidal volume times respiratory rate, the same thing. But you know their own problem is that there's increased elastic recoil. They are restrictive. They cannot expand. They try to come together. And you don't want to deliver more volume, more tidal volume that's going to increase that elastic pressure. So what do? You keep the tidal volume minimal while you increase their respiratory rate. So that's why you want to give them, rapid breath, rapid shallow breath, rapid shallow. That's what they need to survive. Rapid shallow breath. That's it. That's what is okay for them. They don't need large tidal volume. So that's why their tidal volume is kept at 6. In an example of restrictive lung disease like ARDS, why you increase their respiratory rate. For example, fibrosis, respiratory rate increase is good for them. But you have to keep the tidal volume low. Now, okay, I've explained it here. So this is now respiratory rate. I've used one stone to kill two birds. So the rate is generally set lower for obstructive lung disease as opposed to ARDS that you have to increase the rate. So if you don't want to waste your time and be thinking too much in the exam, or you can just use the acronym RR. Restrictive lung disease, increase respiratory rate. Reverse is what you are going to do for obstructive lung disease. At times, those kind of code can actually help us. Just be sure that your code is accurate too, so that you're not going to be picking wrong answer. If you are sure that, okay, I don't code this thing well for spontaneity. So RR, once I identify that the pathology is restrictive lung disease, I'm definitely going to increase the R component, which is respiratory rate, and minimize the work of breathing for them. So FiO2 is the function of inspired air, that is oxygen. We remember that I said, who remembers the parameter that we said we are going to use to increase the oxygenation? Anybody remembers the parameters to increase oxygenation?
We talked about FiO2 and PEEP.
FiO2 and PEEP. And we said that day that the way you are going to set your mechanical ventilator for this PEEP is that you are going to start at 100. Then you now be titrating it downwards till you get to the ideal oxygen saturation, which is around 88 to 95%.
93. Oh, yeah, okay.
Yeah, 93, depending, they are just opening the range because of different disease, then 55 to 80. So, but we must always remember that you don't want to keep your FiO2 more than 60 because of oxygen toxicity. Oxygen can generate free radicals, it can destroy surfactant, can lead to inflammation, can cause fibrosis at the end of the day. So you want to keep your FiO2, titrate it down to less than 60, then you stop. So there's this ARDS net PEEP blah blah table to guide how you are going to titrate your PEEP. I don't think we need to worry ourselves about it. The most important thing to just know that you must not overshoot your PEEP to more than 60%. You keep it below this value so that you reduce the incidence of oxygen toxicity, and you have to balance your FiO2 with your PEEP, because those are the two things that will help oxygenation preventing airway collapse in ARDS. Because ARDS, there's no surfactant, increased surface tension, the lungs come together, they collapse. It is PEEP that we are using to recruit those collapsed alveoli to keep them open. Then you are now delivering more FiO2 so that you can increase, oxygenation of the lungs. So, but at the same time, you also don't want to over PEEP, because if you over PEEPed, they can be tilted towards barotrauma. Barotrauma means pressure. Trauma means damage. So pressure damaging the alveoli due to over PEEPing. So some people can be exposed to barotrauma due to over PEEPing or due to over play-to pressure. So we'll get there. I think we are going to see it. So so what's it called? Of course, if you over PEEP, play-to pressure is going to increase because play-to pressure is a function of your PEEP too. So for obstructing, you want to start with PEEP of 0 to 5. So this is the ideal range. It should not be more than 5. So there's something we call the inspiratory-expiratory ratio. So you can also do some settings in the mechanical ventilator that can influence the inspiratory-expiratory ratio. And what is the value that we want to achieve in somebody with obstructive lung disease? Do you want to make the expiratory ratio longer, like this expiratory value? Do you want to make it longer or shorter in obstructive lung disease? Anybody?
You want to make
You
it
want
longer.
You want to
to
make
be
it
Short,
longer.
Longer.
Exactly.
Yeah.
So the
obstructive
inspiratory
airway.
so the inspiratory
Okay.
to expiratory time ratio is higher. So please
Mhm.
forget about this higher stuff. The most important thing is look at the values, because some people be talking higher, some people be talking lower. It can be confusing. Me, I don't use inspiratory respiratory time. I look at the value. Okay, 1:3. Yeah, this one is actually higher than 1:1.5. So this one would be very good for somebody with obstructive lung disease, while a lower one would be very good for somebody with restrictive lung disease. So we already know this adjustment. If you want to increase PaO2, you must increase your PEEP or you increase your FiO2. Easy. Ventilator adjustment. If you want to increase PaO2, for PaO2 to drop, it means that this person has hyperventilated, right? So you must reduce that ventilatory rate by reducing tidal volume or respiratory rate. For somebody to take care of someone that has hypercapnia, you must increase ventilatory rate, which is by increasing respiratory rate or tidal volume. So we must also be careful of some certain condition. For example, somebody with ARDS now that has tidal volume situation where low tidal volume is very yeah. So ARDS that has hypercapnia. So if you are to choose between which parameter you are going to increase ventilation, it's better you increase your respiratory rate. It's better you increase your respiratory rate, because if you increase tidal volume, that stuff that we said, over distension, and it can, remember we said this, you don't want to over distend with your tidal volume and burst it. And at the same time, tidal volume will also increase the elastic pressure, which can also worsen the problem. So what are the complications of mechanical ventilation? A lot of complications, particularly ventilator-associated lung injury and hypotension. Most of the time, when you see hypotension, you know that there is an emergency that you need to, most of the time, can be due to pneumothorax most of the time. So you want to quickly look out, for whatever is happening in that patient. So let's look at them one by one. These stuffs can increase mortality and morbidity. So the first one is volutrauma. This one is very straightforward. If the anesthetic, person set the tidal volume to be too much, more than 8 ml per kg, is too much. It's going to lead to more volume being delivered, can lead to overdistension and collapse of the alveoli at the end of the day. And one thing that happens when there's collapse is that you have hair leaking around the lung parenchyma, and you can have those hair seeping into the pleural cavity, causing pneumothorax. Very, very common. So you can prevent this by using low tidal volume. Barotrauma, of course, increase peeping, increase plateau pressure. So that's due to high pressure. So you don't want to give too much pressure to, you have to be careful. And you want to ensure that your plateau pressure is less than 30 centimeters of water to minimize barotrauma. 30. Please don't forget, 30. FiO2 less than 60%. Plateau pressure less than 30. There's something we call atelectrauma. So atelectrauma is due to cyclical opening and closing of alveoli. This is very common in individuals that have low PEEP, so that there's nothing keeping their, maybe the mechanical ventilator was set to low PEEP. So as the individual is breathing out, the alveoli are actually collapsing, bam. But the person is delivering positive inspiratory pressure, opening them again. So that can be traumatic for the alveoli. It can lead to systemic inflammatory response syndrome, which could lead to widespread damage to the alveoli. So you don't want that to happen. So what you do is that you increase the PEEP so that there's a very low tendency of the alveoli to collapse at the end of expiration. So they remain patent and open. So you don't need to be open and closing it every time. So that is atelectrauma. So barotrauma is usually a consequence of these three. Very common with volume and atelectrauma. So, generate free radicals, which can lead to severe inflammatory response and destruction of the alveoli at the end of the day. So when your systemic inflammatory mediators come into play at the end of the day, either from atelectrauma or from volutrauma, there's inflammation and destruction of the alveoli, and that's going to lead to hypoxemia. And that hypoxemia can lead to something else. It can even cause increased intrathoracic pressure, which we are going to talk about. Then the last one is oxygen effect. Too much oxygen. How can you deliver too much oxygen? You have delivered a very high FiO2. When FiO2 is too much, it's going to cause lung damage. Yeah. So, and this is very less likely when the FiO2 is less than 0.6. So too much oxygen washes out the surfactant, generates free radicals, which can lead to inflammation, edema, and eventual fibrosis of the lungs. So you don't want that. You don't want volutrauma, you don't want barotrauma, atelectrauma, oxygen effect. There's a last one that is called ventilation-associated pneumonia. I think we'll talk about it maybe when we get to pneumonia, but the summary is when somebody develops pneumonia-like symptoms within 48 hours. So after 48 hours of mechanical ventilation, and somebody starts developing fever, cough, dyspnea, that this is likely to be ventilator-associated pneumonia. So there are so many risk factors. Number one, very common risk factor is when the patient is held supine for a long time. So that can easily allow for reflux, of GI content or oropharyngeal bacteria or secretions into the airway, leading to the pneumonia. So what you want to do is you want to make sure that you elevate their head at 30 to 45 degrees to reduce that aspiration. Number two is frequent movement of the patient. When you are moving the patient way tube dey in mouth for a long time, you are moving, it will get to a point that either the endotracheal tube can kink or there can be a shift in the tube, which can lead to, passage of secretions into the airway. So you don't want to be moving them from time to time. Number three is when you place them on PPIs. Some people will think they are doing them good, but you are not doing them good. When you place patients on mechanical ventilator on PPIs, you are killing, you are reducing the acidity of the gaseous secretion, and you are producing or providing a more fertile ground for the bacteria to proliferate. So the bacteria can easily ascend upward and go into the airway, and it can cause pneumonia. So you want to keep them off PPIs because of that. So another one is too much, sedation. When they are sedated excessively, they might not be able to handle secretion, and secretion will now start pulling too much. When secretion itself done too much, if you overpower the ability of the mechanical ventilator tube, and you have an increased tendency of aspiration leading to pneumonia. So I think we are still going to talk about it. And it's very, very important to understand that PEEP can be beneficial in an individual with left heart failure. Clinically important, very, very important, because when you give somebody increased PEEP, that's going to increase intrathoracic pressure. Intrathoracic pressure increase is going to lead to kinking of the pulmonary vein. There's pressure there. So it's going to reduce delivery of preload from the pulmonary vein into the left atrium. So that failed heart is going to be relieved of the stress, and it's going to calm down. And when preload is reduced, there's going to be reduction in the blood pressure, because less blood flow is going to get to the left ventricle from the left atrium. Less blood is going to get to the aorta. The pressure there is going to reduce, and the afterload is going to reduce. So left heart failure, PEEP is very good for them. But somebody that has right, they will not like PEEP. You must not PEEP anybody that has right heart failure, because if you PEEP them, you are going to increase the pressure within the pulmonary artery, the other part of the pulmonary vasculature, particularly the pulmonary artery. And that's one that is relevant here. And that means that there's an increased afterload in the right side. So if that right heart has already failed, it means that it cannot pump blood across the pulmonary artery, and blood is now pulling in the right atrium, in the IVC, in the SVC. So with PEEPing, we are further increasing the afterload, heart, the pulmonary vasculature, and the blood will keep going back to the systemic circulation, worsening that right heart failure. So that's why most of the time, when you want to treat someone that has right heart failure, they are preload dependent. You have to keep bombarding them with fluid. So you don't say that this person has conceived pericarditis and having increased, they will bombard. You give IVF. Very, very important. You give them fluid because they are preload dependent. People with right heart failure. So, so that is that. It can also lead to acute brain injury and stroke. And
Sorry, can you take this heart failure issue again, please?
wow, Dr. Antonia, you didn't get it. Okay.
Yeah.
So, like what I was saying is, somebody with left heart failure, you know that in heart failure, you don't want preload to increase, right? That's why you give ACE inhibitors and the likes. So, if you increase PEEP in someone that has left heart failure, it is good. Why? Because when you increase that PEEP, you are going to increase the pressure in the pulmonary artery, pulmonary capillary, pulmonary vein. And when there's an increase in pressure in these three areas, they are not going to deliver much blood to the left atrium. Do you get that? So it means that there's less blood, going to that already weak heart. So the heart is going to be relieved of its stress. Do you understand that side of left heart failure?
Yeah.
As in the PEEP causes an increase in intrathoracic pressure.
Mm-hmm.
Is it the intrathoracic pressure that
Okay.
is what I
Okay.
think where the confusion is how does the intrathoracic pressure, how does it
Okay,
Yes.
this is it. You know that PEEP is the pressure in the airway, in the lungs, right? At the end of
Mhm.
expiration, the lungs occupies the thorax. Abi, the lung is the major organ in the thorax. So anything that happens in the lung is going to affect the thoracic pressure. So because of that increased positive end expiratory pressure in the lungs, there's an increase in the intrathoracic pressure too. Abi, Dr. Antonia. So this pressure is going to be transmitted to the pulmonary vessels, because the pulmonary vessels are the vessels supplying the lungs. The lungs are in the thorax.
Mhm.
Like this is the same mechanism of why somebody that has what's it called? All these our Paux's paradoxicals, It's the same principle. So
Mhm.
if you increase the PEEP, you increase the intrathoracic pressure. The intrathoracic pressure is transmitted into the pulmonary vessels, which are the vessels of the lungs in
Mhm.
the thoracic cavity.
Mhm.
And when you exert pressure on the vessels, it's going to reduce flow within those vessels.
Mhm.
And
Yes.
when you reduce flow from the pulmonary vein into the left artery and into the left atrium, do you think
Mhm.
are you not lessening the burden on the left side of the heart? You are lessening the
Yes.
body on the left side.
Yeah.
So the person can easily come out of that left heart failure because it doesn't have much blood to be pumping.
Okay. Mhm.
But it's not going to help someone that has right heart failure. Why? Because if somebody has right heart failure, if you want to help the person, you can only be talking about affectation of the SVC and the IVC. But
Mhm.
what is going to be affected by the increased intrathoracic pressure are the pulmonary vessels too, particularly
Okay.
the pulmonary artery now. When you
Mhm.
increase pressure in the pulmonary artery, what is going to happen to the afterload of the pulmonary artery is going to
It
increase.
Increase.
please. Uh,
Mm,
So that
what's
means that it's going to
okay.
worsen the heart failure.
okay. So the increase the high or the increase in thoracic pressure, what it does is in a way causes like pulmonary constriction. Right.
Yes, it
Okay.
causes pulmonary constriction.
Yeah. So it affects both the veins, the pulmonary veins and pulmonary artery.
Yes, it affects
Okay.
both the pulmonary veins and the pulmonary artery.
Okay.
Yes.
Got it. Thank you.
So for acute brain injury, your the target is 94 to 98, and the PaO2 is the target is 80 to 100. So to help the brain oxygenate. But if we give a value um, less than this, there can be problem. So both very, very high PEEP and uh, hypoxemia can lead to increased intrathoracic pressure and cause cerebral edema because high PEEP can lead to barotrauma. High PEEP can rupture the alveoli, and when they rupture, that is hypoxemic insult automatically. And when there's hypoxemia, the cerebral vessels will start dilating so that they can increase the blood flow. When we remember the Morrow-Kelly something hypothesis, so
Mm-hmm.
when there's an increase in blood flow to the brain, there will be an eventual increase in intracranial pressure.
Intracranial pressure.
And when the intracranial pressure increases to some extent, particularly more than the mean arterial pressure, it's going to start kinking on the intracranial vessels, the cerebral vessels supplying the brain. And there's going to be ventral cerebral ischemia. So that's why another reason why IPEEP can be dangerous, because of the fact that it can lead to alveoli destruction and eventual hypoxemia. So that's why we must keep it within this range. We must keep oxygen level within this range. You must not over PEEP and drop the oxygen level below this. It's going to cause problem, particularly in
Dr.
people with
Papale, please, just again, please, can you explain SpO2 and PO2?
okay. So P small aO2, I think that's what you meant. P small aO2 is talking about the partial pressure of dissolved oxygen in the lungs, in the blood. Dissolved. Because it is oxygen that is dissolved that is exerting a pressure. Some of that oxygen is going to bind to hemoglobin. They are going to saturate hemoglobin. Those ones are not contributing to PaO2. Those ones are the ones contributing to SpO2. But everything will be affected by oxygen delivery. If you have anything that is impeding crossing of oxygen across the respiratory membrane into the blood, it's going to drop both of them. But you remember, there are some conditions that will not affect both of them. For example, someone that has carbon monoxide poisoning, which one do we think is going to drop in carbon monoxide poisoning? Which one will be normal? Anybody?
Saturation will drop.
PaO2 will drop.
PO2 will be normal.
You said?
I said PaO2 will drop.
No, saturation will drop and PO2 will be normal.
Yes. You know that in carbon monoxide poisoning, it's kind of reducing the affinity. It's not that it's reduced. You see, the pathophysiology of that carbon monoxide one is a little bit confusing. What it does is that if hemoglobin has 4 spots for oxygen, carbon monoxide will attach to one. What it will now do is that it's going to allow oxygen to bind to the 3 that is remaining. That's what carbon monoxide will do. But you know that the saturation has dropped by 1 for that particular single molecule of hemoglobin. I don't know if we get that. There's 4 sites for oxygen to bind in hemoglobin. What carbon monoxide will do is that it will bind to 1 site or 2 sites, but it will not bind to everything. But it will allow oxygen to bind to the remaining. But because of the fact that carbon monoxide is already occupying some spots, oxygen cannot bind to the 4. So the saturation of that hemoglobin for oxygen will reduce. Do you understand?
Yes, it's clear.
But there are some oxygen that's already dissolved in glass, in blood. Carbon monoxide have no effect on that one. So it is normal. It is normal. So, but at the same time, carbon monoxide will increase the affinity of hemoglobin to oxygen. So that is why it shifts the curve to the right. Abi? Anybody?
No, it shifts.
It's left
Carbon
now.
monoxide
It doesn't
shifts to
shift
the
to
left.
right. It shifts
Left,
to
the
left.
left,
It shifted to the left.
Because it's binding more. It has more affinity for it.
Exactly. So that's what carbon monoxide is going to do. So some people can be getting confused. Why is it shifting it to the left? It has no affinity. Why? How is it happening? Why is it now dropping saturation? So that is it. It's occupying some sites, not allowing oxygen to occupy to all the sites. So the SpO2 can never be 100%. But because of the fact that its binding increases the affinity of the other sites, to oxygen. So they will adhere to that oxygen and they will not release it. So it will shift it to the left. The same thing for methemoglobinemia. The same principle. The same principle. So that is that. So we have talked about the other complications. So this is for hypotension. So hypotension, we are looking out for 3 things. Tension pneumothorax. So suddenly the patient suddenly became hypotensive, reflex tachycardia, and you check your pressure, you see an increase in the peak inspiratory pressure. It can be increase in the platelet pressure. Of course, if platelet pressure don't increase, peak inspiratory too will increase. So you know that there's likely to be tension pneumothorax, because that's the only condition out of this abnormality that we have said that can really cause hypotension like that. Atelectasis will not explain hypotension. To brainstem intuition, no. Pulmonary edema, no. ARDS, not really. But pneumothorax can cause obstructive shock, which can lead to hypotension. So you want to watch out for that. So hypotension in somebody with mechanical ventilation with a sudden increase in the peak inspiratory pressure, particularly you now noticing that from actually the platelet, you know that this is likely to be a tension pneumothorax. You order your chest X-ray, and you do your needle decompression. So decreased venous return. So high level of PEEP, just like we have explained, high level of PEEP can reduce venous return to the left side of the heart, and that can also exacerbate hypotension. Sedative and opioids, these are part of the agent that they use, for people that they want to place on mechanical ventilation. So they can also cause hypotension in the long term because they can cause vasodilation, and they also have a negative chronotropic and inotropic effect on the heart. So they will drop the heart rate, drop the contractility, vasodilate the vessels. All of those things in concert will lead to hypotension. So looking at COVID, we are not going to waste more time about COVID. We already know COVID very well. All this story, we are familiar with it. We know that it started in Wuhan, China, and what I just want us to take home is that COVID-19 is associated with an exaggerated systemic inflammatory response to the virus. That is it. Exaggerated inflammatory response to the virus, leading to cytokine storm. You just see cytokine running around everywhere in the blood. They are firing abnormally. So you're going to have fever, multi-organ dysfunction affecting the kidneys, the brain, the lungs, the liver, everywhere is affected. Let us look at this question. A 25-year-old man in the ICU is intubated following an acute asthma exacerbation. A repeat ABG is sent after intubation and shows a pH of 7.5, PaCO2 of 33, bicarbonate of 26. What adjustment, if any, should the physician make to the ventilation setting? Anybody wants to help us?
The patient is having respiratory alkalosis, isn't it?
The
Yeah.
patient shows alkalosis.
Alkalotic.
So what
Yeah.
are we going to
And
do?
Having
Yeah,
respiratory
is
alkalotic is increasing, so the patient is having hyperventilation.
Okay.
yes.
So what do we do?
So
you try to
reduce
reduce the
respiratory
ventilation. You reduce the
Respiratory rate.
rate. Reduce the respiratory rate.
Respiratory rate.
Nice. Yeah, so we can actually reduce the respiratory rate or tidal volume, but
peak
don't
respiratory
forget.
rate.
I know that we usually forget that stuff. We now concentrate on respiratory rate only. We must remember that what we are altering is ventilation. So don't say
Okay.
the respiratory rate. So you say because you have said that the patient is hyperventilating. So
Mhm.
regulate ventilation. Ventilation is a product of tidal volume and respiratory rate. So you can either increase tidal volume, you can either decrease tidal volume or decrease respiratory rate. But we will preferably decrease respiratory rate. So we will always be correct. Because if you go and decrease tidal volume, it will trigger.
It's obstructive.
Yeah,
Yes.
that little volume that we are taking it will trigger increase in the respiratory rate. So it will be counterproductive at the end of the day. So
So please, can you explain again how sedatives and opioids can cause hypotension?
vasodilation, decrease in inotropic and chronotropic activity of the decrease in the heart rate and contractility, as well as vasodilation.
Wow.
Yeah. So the virus is spread by respiratory droplets.
He's asking you how.
How?
Yes.
Is that what you are saying?
How?
Yes. How is it the sedatives, and is it by suppressing the brain?
Not that, but maybe they affect CMP. I don't really know the exact, mechanism, but it has been reported that they actually have that effect. But I don't really know much about the mechanism, so I might not be able to give you a response now. But maybe we can check. Let's check. But if you check some journals, you will see it like that.
So, but how we need to know is that sedatives and opioid, they decrease blood pressure through the effects on vasodilation and then decrease in inotropic, right?
Yeah.
Okay.
Analgesic and opioid this do have a retention and the payload by cardiac function. So it's not something that it's just from research. That's just it. But if you need to know more, Dr. Antonia, you can check. You can check. Yeah.
Okay.
So so for the
Dr. Babale, I just have one quick question for you before we deep in further.
okay.
When you were talking about that hypotension, you said it's what's it called? That when you were talking about acute hypotension, yes, you were talking about the effect of tension pneumothorax, in that it causes what's it called? That hypotension is caused by peak inspiratory pressure. So,
Okay.
but for the restrictive and then the decreased compliance, increased restrictive and decreased compliance you've given us earlier, they also have increased PIP or as well. You
Uh,
it's always increased in both of them.
yes.
So,
Yes.
how do you now isolate it to know? Is it going to be the clinical scenario they will give you that will make you know that this is exactly what you are looking for, right?
So I just want to clarify something. Are you
Mhm.
separating um pneumothorax from the restrictive pattern?
Well, the last one, that was why I was surprised because you when you were talking, you actually removed, you were talking about that it's not like pulmonary edema, which we see
Yes, exactly.
in
Okay,
all
I
the
get the question now.
yeah,
So what I said was hypotension.
yes, hypotension, yeah.
Yes. So we will not see because pulmonary edema will not cause hypotension.
Mm-hmm.
Pneumonia, or maybe from sepsis, but you know, what's it called? The other ones that are there, atelectasis,
Physiology, yeah.
main stem intubation, all those ones will not cause hypotension. So that's why they said don't do needle compression immediately. Just have a heightened suspicion for tension pneumothorax. Because just like we have said now, what's it called? Pneumonia from maybe there's a underlying that has become septic can lead to hypotension. So do your X-ray to see whatever is there before you now intervene. You know that by the time we get to maybe multi-system or something, we're going to talk about management of tension pneumothorax. If you are suspecting tension pneumothorax from you don't even do X-ray. They don't do X-ray before you treat someone that has tension pneumothorax. In fact, tension pneumothorax is the only stuff that uh you don't even need to follow the ABCD protocol. We can check it anywhere. You don't follow ABCD protocol before you to put needle inside the back. Like it's because it's very dangerous.
You
So
don't have time. You don't even have time, so you do it
yes,
yourself.
you don't even have
You don't.
time. So you do it straight up. So that's why they are just saying you should have an increased suspicion for tension pneumothorax when you notice a drop in the blood pressure and a feature of elevation of the pressure, particularly the platelet pressure. But you know that if platelet pressure is increased, it's going to also cause increase in the PEEP. So, but to narrow it more further, you will notice that it is actually the PEEP. So that because someone that has asthma too, or someone that because maybe mucus plug obstructing the airway, they can also have increase in PEEP. But it's going to be the restrictive pressure that is going to be, increasing them. So not the play two. But once you see that okay, it's a play two that is increasing, I can now start thinking, and you see hypotension, you can think of tension pneumothorax, then you do your chest X-ray to now look exactly what is actually happening. So if it's suggestive of tension pneumothorax, you now do your needle decompression. Do you understand that, Dr. Oloroti?
Yeah, thank you.
So the virus is spread by respiratory droplets. The incubation period is 5 days, average of 5 days. Um, depending on the immune status, it might be asymptomatic or they can be mildly symptomatic or be severely symptomatic, depending on the background, immunity of that patient or the comorbidities that the patient have. So people with diabetes, hypertension, CKD, they can actually have it very, very worse. So most of the time you just see these normal non-specific symptoms like fever, cough, sore throat, nasal congestion. The nasal congestion part is actually telling you that this is likely to be viral. So the sore throat, nasal congestion might be viral. Then the very specific ones for COVID, anosmia and acute. So loss of smell and loss of taste. So if you tell us in the question stem somebody having features of upper respiratory tract infection and suddenly develops problem with smell and taste, okay, you know that okay, this problem probably COVID. that we are working with. So aside the respiratory symptoms, you can also see some GI manifestation like nausea, vomiting, diarrhea. So it can be very, very bad. Just like we said that it's multi-systemic, it can affect the lungs, causing ARDS, leading to respiratory failure. Of course, the reason is not far-fetched. We already said it that I share with cytokine storm. So the cytokine can get to the lungs, vasculature, and it can cause ARDS and lead to shock. It can affect the kidneys, the liver, the bone marrow, different organ. And one thing about it is that it's highly associated with coagulation. So they have this numerous thromboembolic events. So PE easily occur in people with COVID. A lot. So the most sensitive test to do to make diagnosis is the NAT, which is a reverse transcription, PCR test of the nasopharyngeal sample, because of course it is a respiratory tract infection. So you want to obtain the nasopharyngeal sample to make your diagnosis. But sometimes you can also do rapid antigen testing, particularly at point of care, because it's very, very fast, but it's not as sensitive as the NAT. So you can just quickly do it. You pick anybody, you tell them, go and isolate yourself, and if it gets worse, present to the hospital. So for people that are bad, you can continue the investigation by doing the chest x-ray, which is going to reveal bilateral opacity. So it's just like someone that has all those atypical infection, having this bilateral, opacity, but there are some, and that is ground glass. You remember, this is like in keeping with what we have in people with PCP, because people with COVID too can have background immunosuppression. And the question is going to be talking about somebody having bilateral ground glass opacity. I'll be thinking, is this PCP? But there are some things that sets COVID apart. Number one, it's the distribution is more in the lower lobe for COVID. So we are going to be seeing the ground glass opacity more at the lower lobes, as against PCP that occurs more upper middle lobes. That's PCP. But COVID, lower lobe. In COVID, we are going to be seeing features of consolidation. Consolidation is not very common in PCP. Then lastly, the distribution of the stuff is peripheral for COVID. Peripheral, you see at the periphery, of the chest x-ray. While for PCP, they are central in distribution. Bilateral but central. COVID is bilateral but peripheral. COVID will have consolidation, and the consolidations, the opacity will be at the lower lobes. So just like we have here, CT talking about the consolidation, and we can see the airway bronchogram. This stuff that looks like tube, these are the airway bronchogram. So it's like showing air-filled bronchial cavities being enhanced by the surrounding parenchymal opacity. So airway bronchogram, they are good features of COVID too. So the dense, right and lobe opacities with the airway bronchogram, you see them, people with COVID. So the laboratory finding, just think of systemic problem. So if there's problem with the bone marrow suppression, the blood count is going to be down. So lymphopenia, anemia, thrombocytopenia, because of the fact that it's highly associated with coagulation, so there's going to be elevation of the D-dimer, formation of clots, a lot. The inflammatory markers will be up, C-reactive protein is over the roof. Because of affectation of the liver, you have elevation of LDH, ALT, AST, and the kidneys too can cause elevation of creatinine. So this is very common in hospitalized patients with very severe form of the disease. So how do you want to treat them? For mild cases, you just want to tell them, go home, isolate yourself, just lock yourself in the room, and the person should be placed on observation. When the stuff gets worsened, you might want to take symptomatic treatment. When it gets worse, you might want to present to the hospital. You just do symptomatic treatment generally. Give antibiotics for the fever. If there's any serious coughing, chest pain, headaches, give analgesics. antitussive for the cough, and hydrate because of systemic inflammatory response, consuming a lot of fluid. So from the increased metabolism, hydrate the patient. So patients that have mild to moderate disease that have a very high risk of progressing to severe, you might want to treat them with neutralizing antibodies or antiviral. So people that don't have it very bad, you just give them the antibiotics, the analgesics, the cough suppression, and the fluid. But when they have a very high risk of progressing due to some underlying comorbidities, you can prep them by giving them neutralizing antibodies. There are a lot of them. Most of them neutralize the spike protein of the COVID, or some antivirals like I have here. Ritonavir is used in HIV. Remdesivir is also used, to treat the COVID. But for severe cases, ARDS, severe liver injury, kidney failure, inpatient immediately. Inpatient care is needed. So, how do you treat individuals with COVID? Or how do you prevent, rather, sorry. Preventive strategies. We already know this. We did it a lot in 2020, 2021. Social distancing, 6 feet, wear your mask, don't shake hands, wash your hands. When you shake hands or when you touch people, touch surface, use your hand sanitizer, reduce out-of-face contact, good ventilation in our homes. Preventive strategies. These are things we can think about. They're not really highfalutin stuff. So strategies for the healthcare personnel. You want to ensure that you are on PPEs, personal protective equipment, wear your gowns, your high protections, gloves, particularly these are highly needed, in people in healthcare setting and the likes. Then, if they get engaged in any aerosol generating procedures, they must wear the respirator, this N95 mask. This mask is very good because it fits tightly to the nose, to the mouth, and it can filter any air that is being breathing. So any air they take in, it filters it, makes it devoid of microbes and the like. So it's very, very good for aerosol generating procedures like the patient being suctioned, bronchoscopy being attempted, passage of NG tube. All these stuff can generate respiratory droplet and aerosol that can lead to spread of COVID. So you also want to vaccinate people that are healthy, as well as people that have the infection, so that it doesn't progress to a very bad one. So so this is the answer to the question we answered initially. So let's just wrap it up by talking about pulmonary hypertension. So pulmonary hypertension is a condition which is associated with elevated mean arterial pressure beyond 20 millimeters of mercury at rest, not after the person have exercised, but at rest. We should discard the previous one, which is 25. It was criticized because there was no supporting evidence. So now the value is 20, less than 20, greater than 20 rather. Mean pulmonary arterial pressure greater than 20 at rest is pulmonary hypertension. So we have 5 different categories. The first group is talking about the one that share with the artery itself. So I think I should use the step 1 because step 1 is more explanatory. So the first one is the pulmonary arterial hypertension. So that's the first group. It can affect the artery, it can affect the vein. So that the vein one is the left heart disease. It can affect the capillaries in a way. So that's the lungs. Then thrombus. So that's the way to look at it. Artery, vein, capillary. Artery, vein, capillary. So the artery might be idiopathic. Very common in females more than males. And what is the problem? The problem is due to inactivating mutation in the bone morphogenetic protein receptor 2 gene. The bone morphogenetic protein receptor 2 gene. So this gene product usually inhibit vascular smooth muscle proliferation. So um, anybody that have problem with this gene will not be able to inhibit the vascular smooth muscle proliferation. So this predominantly affects that of the pulmonary vasculature, and you have abnormal proliferation of their smooth muscles. They become abnormally thick, leading to narrowing of the caliber of the airway. And it's important to also know that the prognosis of idiopathic one is not too good, because you just be doing like symptomatic, not a symptomatic treatment, but you cannot treat the underlying cause because you don't even know the underlying cause. So one thing that is common to the idiopathic form of this pulmonary arterial hypertension is that there is actually vasculature endothelial dysfunction. So there is more expression of the vasoconstrictors like endothelin, and reduced expression of the vasodilators, which is nitric oxide and prostacyclin. So prostacyclin is a pulmonary vasodilator, nitric oxide is a pulmonary vasodilator, while endothelin is a pulmonary vasoconstrictor. So this guides the treatment of group 1. Because scientists have discovered that this is the pathophysiology of group 1, so they now decided to use inhibitors of vasoconstrictors, stimulators of the vasodilators to treat group 1. And it makes a lot of sense. So that is why we are not going to be picking prostacyclin for treatment of lung disease causing pulmonary hypertension. That will not be correct. It's very good for people with the group 1. So there are other causes of the pulmonary arterial hypertension aside the idiopathic ones. Either the person is on drugs, cocaine, amphetamines, they can cause vasoconstriction normally, so leading to the hypertension. You know that they can also cause vasoconstriction in the systemic vessels, so they can cause hypertension anywhere. Connective tissue disease like scleroderma, which is associated with fibrosis, connective tissue deposition, collagen deposition everywhere, can deposit their collagen within the pulmonary arterial vasculature, leading to narrowing and hypertension. HIV, studies have shown that immune dysregulation in HIV might provoke some inflammatory response within the vessels, the pulmonary vessels, leading to thickening of the vessels in HIV. The portal hypertension one is associated with a drop in serotonin levels. We remember that in pulmonary hypertension, there is reduced flow to the liver. Because of the hypertension, blood is not actually getting to the liver. So blood is supposed to be filtered, removed, the what's it called, the inflammatory mediators, the vasoactive agent are supposed to be removed from the blood coming from the intestine, is not removed. So that blood is being channeled directly through the collaterals, and it gets to the systemic circulation, and from there they can travel to the lungs. And because of the fact that they are very rich in serotonin causes fibrosis. Remember that people with carcinoid syndrome, they can have tricuspid regurgitation and pulmonary stenosis. Who remembers? Hope we remember.
We do.
Yes, and that is due to the effect of serotonin causing the fibrosis. So the same thing happens here. Serotonin gets to the pulmonary vasculature, fibrosis, portal hypertension. Congenital heart disease, this one is just straightforward. Left to right shunt, VSD, ASD, PDA. Left to right shunt, overloading the pulmonary arterial side, hypertrophy and remodeling, fibrosis, and hypertension. Schistosomiasis, their own comes from inflammatory response to the egg. So you can have embolization of the eggs of these schistosomal infections. When they travel, because they are very small, they can get to the pulmonary vasculature, and they provoke serious inflammatory response, leading to fibrosis and hypertension. The people with the category 2, they are those ones with the problem with the vein, left heart disease. So if somebody has mitral stenosis, mitral regurgitation, aortic regurgitation, and you have a lot of backflow of blood, to the pulmonary vein. That, volume of blood backing up in the pulmonary vein can cause remodeling of that vein, hypertrophy. And at the end of the day, the caliber of the vessel is going to narrow, and it will cause pulmonary venous hypertension. And that pressure is going to be transmitted back to the capillaries, to the artery, and to lead to hypertension at the end of the day. So there's a test that you can do to differentiate pulmonary arterial hypertension from idiopathic or from all these ones, from the one from left heart disease. And the simple test to do is just to measure your pulmonary capillary wedge pressure. Your pulmonary capillary wedge pressure is going to be elevated in left heart disease, but it is not going to be elevated from all these other ones, because these ones are affecting the artery majorly. So it can come from valvular heart disease, just like we said, mitral stenosis, mitral regurgitation, aortic regurgitation, backflow of blood back to the veins, or people with systolic or diastolic dysfunction, heart failure generally, heart failure from any cause, MI, just think of anything, ischemia, hypertension, think of anything causing heart failure can lead to, the venous hypertension. From lungs or hypoxia. So at the end of the day, the capillaries, because that's where the exchange is happening. So, destruction of the lung parenchyma, either from COPD. People with COPD, they have problems with their respiratory membrane, particularly emphysema, where the respiratory membrane integrity is being compromised. And sorry, please, just a minute. Okay. So from the lung disease, COPD destroy the alveoli membrane. Oxygen is not getting to the blood. There is hypoxia, and we remember that one of the response of the pulmonary vasculature to hypoxia is what? Pulmonary vasoconstriction. Lung inflammation, fibrosis too, either from interstitial lung disease or from any damage to the lungs. Interstitial lung disease generally, they can cause fibrosis of the lung tissue, and that can even affect the vasculature themselves, constricting them, leading to pulmonary hypertension, or any condition causing hypoxemia, which is outside the lungs, from maybe breathing in high altitude, or people with obstructive sleep apnea that they cannot ventilate because of obstruction in the airway. They are going to have hypoxemia, and it's going to cause vasoconstriction of the pulmonary vasculature. So that's from group 3. Group 4 are just people that are prone to recurrent thromboembolism. So recurrent microthrombi formed within the pulmonary vasculature can actually reduce the surface area. Please, hope you can hear me.
Yes, Dr. Babawale, we can.
So it can reduce the surface area. That's the problem there. It reduces the surface area, reduce the caliber, and can lead to pulmonary hypertension. That's group 4. So this is very common in people with malignancy, people with splenectomy. So people that have undergone splenectomy can have reactive thrombocytosis, because the spleen does the function of breaking down those thrombocytes. But when the spleen is no longer there, they are there. The thrombocytes are just playing around, forming clots. So malignancy, splenectomy, people with some thrombophilic condition like factor V Leiden, antithrombin 3 deficiency, antiphospholipid syndrome, they can have group 4. They can have this. Very, very common. Then the last one is a multifactorial, so which falls under the category of hematologic, systemic, metabolic disorders, alongside with any tumor compressing on the pulmonary vasculature. So somebody having maybe a lung tumor extending, compressing on the pulmonary vasculature, they can have pulmonary hypertension from tumor. People with hematologic conditions, people with sickle cell Sickle cell can have recurrent sickling of the blood, and that sickled cells can damage the endothelium and can lead to this problem. So when the endothelium is gone, there's nothing to secrete this and this, leading to the hypertension. Systemic systemic conditions like somebody having sarcoidosis. Sarcoidosis can fall under group 3, because sarcoidosis can cause interstitial lung disease too, which will lead to lung inflammation and hypoxia at the end of the day. Metabolic, people with DM can easily damage the endothelium. The inflammatory reaction can lead to obstruction. Even the plaques from the atherosclerosis, everything can narrow the vasculature, leading to pulmonary hypertension. So that's that about the cause of pulmonary hypertension. And it's important for us to know the phenomenon of copper pulmonale, which is very, very classic for group 3, when there's a problem with the lung tissue leading to hypoxic vasoconstriction. So this can come from either somebody having problem with the lung parenchyma, like in COPD, somebody having problem with the inflammation of the lung tissue, like in interstitial lung disease and fibrosis of the lung tissue, or somebody having problem with the outside, but you just have problem getting in oxygen into the body. That's just where the problem is, like in obstructive sleep apnea, high altitude breathing. All those people can also have hypoxemia, which is going to lead to pulmonary vasoconstriction. And when the vasoconstriction happens, there's going to be some alteration or remodeling within the right ventricle, such as dilatation with eventual hypertrophy of that ventricle. When it becomes hypertrophied and it has undergone that remodeling, we call that copper pulmonale. And at the end of the day, it's going to eventually lead to right-sided heart failure. But we don't actually wait for right heart failure to set in before we can call it copper pulmonale. You call it copper pulmonale once there's remodeling of the heart of the right ventricle from a pulmonary problem, either increase in pulmonary viscosity, increase in the pulmonary vasoconstriction, or any alteration in the caliber of the pulmonary vessel from any cause. You can say you have a copper pulmonale. So the presentation, dyspneic, they are going to be dyspneic because there's a reduction in the surface area of the pulmonary vessels. They are not allowing any more oxygen to be transported into the blood, because there is more like an hypertension. There is kind of impairment in the flow of blood. So don't think that hypertension, blood will be flowing. Don't forget that there's a narrowing of the caliber from different causes, either from hypoxic vasoconstriction, or from narrowing from airway remodeling, or from fibrosis. So the hypertension is not actually driving blood. That's why you notice that there's going to be a downstream tapering of the pulmonary vessels and upstream enlargement of the central pulmonary vessels. That's what we call pruning, because of this remodeling. So blood flow is not adequate. They cannot take in blood, and it's going to lead to dyspnea at the end of the day. Syncope on exertion, fatigue, lethargy, all these things are shared with hypoxemia generally. Chest pain when there is copper pulmonale, usually, from the right ventricular hypertrophy and the likes. So, and eventual congestive cardiac failure. These things we know very well, so they are not something we should waste much time on. And we know that the copper pulmonale leading to heart failure is going to affect the right side, presenting as elevated JVP, abdominal distension, hepatomegaly, pedal edema, and the likes. History depends on the cause. Just look at the category A, B, C, D, or 1, 2, 3, 4, 5. So A is arterial, HIV, congenital disease, scleroderma, or idiopathic. B, left heart failure, look for any heart disease. C is pulmonary stuff, interstitial lung disease there, COPD is there, under the hematologic sickle cell. Just look at, depending on, whatever class. But what is very common in terms of the examination finding is number one, you cannot forget this, a loud, palpable S2 because of the pulmonary hypertension. It causes a loud pulmonary S2 that splits. The reason why it's going to split is because, and this splitting is going to be wide, is because it takes a long time for the right ventricle to eventually empty into the pulmonary vessel because there's hypertension there. It's going to do a lot of extra work. So it's going to take longer time for it to close. Yeah, it takes longer time before, but the time is going to be longer. So that's why we say the splitting is wide. You know, wide splitting, loud S2, and a flow murmur. So this murmur is called the Gram-Still murmur. This murmur is very common in people with mitral stenosis as a cause of the pulmonary hypertension. So, mitral stenosis causing pulmonary hypertension, what category is that going to fall into? Anybody? Mitral stenosis.
Is group 2.
Group
But
2.
two.
Group 2.
Group 2. Yes.
So, in mitral stenosis, you have blood going back into the left atrium, the pulmonary vein, the capillary, then to the artery. So, it is an early diastolic sound you hear, due to that regurgitation of blood, from obstruction at the mitral stenosis. So during the diastole, where you have eventual relaxation um, of the chambers, where the mitral valve is supposed to open so that blood can empty to the left ventricle, it will not open. So when the blood is coming, it will just be accumulating in the, you know, um, left atrium, and it will further worsen the pulmonary hypertension, because in hypertension already there's a congestion already too at the pulmonary vasculature. So with that's to where you have more increased blood flow coming, they will all of them will now gather, accumulate, and travel back. So that's why I call it a flow. They will travel back to the pulmonary vasculature. So that will not be a problem in systole, because systole you are doing a forward pushing. So and mitral stenosis doesn't affect systole. In systole you are just injecting your blood gently into your aorta, no problem. But in diastole, where the blood is supposed to fill across the mitral valve, but there's an obstruction there. So in the face of the pulmonary hypertension, you have a lot of blood congesting the pulmonary circulation, causing a flow murmur, which you call the Gram-Still murmur. It is a diastolic murmur. So S4 will be very common when there is eventual concentric hypertrophy of the right ventricle, which is what you expect because of the pressure overload. Parasternal heave is also talking about the right ventricular hypertrophy, and of course there will be hypoxemic on exertion. So we have some etiologies of embolic disease. I don't know why this is there, but just know it. Postpartum amniotic fluid embolism. Postpartum, we suspect this. Postpartum, someone develops sudden difficulty breathing, tachypnea, tachycardia, DIC, want to suspect amniotic fluid embolism. Fracture embolism too. The triad of fever, dyspnea, the rash, and the confusion. So they are confused. They have the petechial rash, and they're also feverish and Disney. Hope I'm not missing the triad. Please, who wants to remind me of the triad again? Fat embolism. Hope I'm not missing out anything.
Heart embolism. That one is after
You're right.
what's called fracture.
Yes.
You're right.
Heart embolism.
I had dyspnea and the petechial hemorrhage. Petechial rash.
Especially on the
Yeah.
lower limb.
Then the CNS manifestation, which is the confusion, the seizure, anyone.
Yeah.
So,
Hypoxia, neurological examination, and petechial rash.
yes. So, cardiac surgery, embolism. Cardiac surgery, taking here, you are trying to maybe mistakenly puncture something, puncture SVC, puncture that. Here can easily leak into that area and it can lead to emboli. And the vascular procedure too can lead to cholesterol emboli. One thing you usually watch out for this cholesterol emboli is this mottled skin appearance. And they are going to tell us that the person is doing angiography or something. So you know that this is cholesterol embolism that is happening. So how do you make diagnosis? The best initial test is echo. the best initial test to make your diagnosis of pulmonary hypertension is echo. So the echo is to estimate what is that pulmonary artery pressure at rest. So it's going to give you a reflection of that pressure, as well as the pressure of the right ventricle in systole, the pressure of the pulmonary artery in systole, as well as the mean pulmonary arterial pressure. Because what we are calculating is actually the mean pulmonary arterial pressure. It should not be more than 20 at rest. So you can also look at the right ventricular function to know if cor pulmonale is already setting in. You want to assess for the thickness, you want to look at the motion, want to look at the wall motion, if there's any abnormality, there's dilatation, and these are stuff that you expect in failure. Dilatation, the hypokinesis, and also valvular abnormalities, because when the heart start failing, regurgitation, so it can even lead to tricuspid regurgitation at the end of the day. So then you can also do your chest x-ray to also corroborate your findings. And just like I've said, pulmonary hypertension, the narrowing of the vessel, so it means that you are going to be having congestion upstream. So there's going to be enlargement of the central pulmonary artery with tapering of the distal one, so which is called the pruning. That's what we are going to see on X-ray. And we should not worry about this, because definitely we will not be asked to be looking for pruning on X-ray. They can say it in the question step. So, and the right heart border might be prominent. You see it's very conspicuous because of right ventricular enlargement. And you can see features of COPD depending on the cause. If we do our ECG, we are going to see evidence of right ventricular hypertrophy, which is R wave in V1. So V1, right stuff. Most of them, when you are thinking of right-sided pathology, V1, lead V1 and lead V2. Dr. Babaride is going to shed more light. It's going to dissect it expertly, and we have a very strong grasp of it when it gets to that time. So V1 more than 7 millimeter, R wave in V1 more than 7 millimeter is suggestive of right ventricular hypertrophy. So, but the diagnostic test of choice that you can do, that that anything I find here, that is it. That's the absolute stuff. Is your right heart catheterized, because you're actually going inside that. It's like an invasive process. So you are going in to detect that pressure. So right heart catheterization is a diagnostic test of choice, and the mean pulmonary arterial pressure will be more than 20 in them. So don't forget, when the PCW is greater than 15, you want to think of group 2. When it's less than 15, it is the others. So how do you treat? You treat the underlying. So don't forget the investigation. Echo is the first thing. You look at the pressure, you look at the functionality of the right ventricle. Then you can now do your chest x-ray to corroborate your finding. You can do your ECG, you know what to look out for. But the best test, if they say what's the best test, it is your right heart catheterization. The best initial is echo. The best test, which is the diagnostic test, the best diagnostic test is right heart catheterization. But the best initial is echo. So if they say accurate right heart catheterization, we should not mix it up. So you give supportive therapy.
Dr. Babawale, what's the rationale behind doing echo first before going for the accurate test?
Yes. So, Dr. Roti, just like I mentioned the other time, catheterization is invasive. So,
Okay.
So you want to be sure that you have a suspicion
Yeah,
before you go in.
Yeah, okay.
Sorry, Dr. Wale, you said PCWP greater than 50. Think of group 2, less than any other group, right?
Yes.
Okay. Thank you.
So supportive oxygen, and this oxygen is very useful, particularly in people with group 3, lung problem. People with group 2 might want to diurese them, give them diuretics to reduce that preload coming to the left side of the heart. So studies have shown that some of them might benefit from exercise. This is still undergoing review, exercise therapy. But let's just stick with what is already sure. Supplemental oxygen, diuretics. Group 3, diuretics. Group 2, oxygen. And if people with group 3 too, if people with group 2 too, sorry, I'm not mixing you up. Hope I'm not making mistake. Group 3, oxygen. Group 2,
It's,
diuretics.
yeah.
Now,
Mm-hmm.
if people in group 2 is also having, very low oxygen level, you should also give them oxygen. So in group 2, which is the heart one, you must give them something that can help them pump blood out. Digoxin can help them, nootropic agents. And because of the fact that most of the valvular problem that causes group 2, the heart one, is from the mitral stuff, mitral stenosis, mitral regurgitation. So you can have left atrial enlargement. And we know the bastard that is there, the left atrial appendage, potential site for formation of clots. So you want to place them on anticoagulants because they are also at risk of developing atrial fibrillation. So for group 1, so we have stylishly talked about management of group 2 and group 3. So for group 1, we already know the pathophysiology, idiopathic for BMR, BNPR2, gene mutation, inactivation, and because it's associated with increased expression of the endothelin receptor, agonist like endothelin 1. So you might give them endothelin receptor antagonists like the setans, bosetan, bosetan, bosetan. I think the common side effect of bosetan is LFT problems. So liver function test for bosetan. I think we should check it up. I think it causes liver issues. So then you can give the prostacyclin agonist, or you give phosphodiesterase inhibitors. Now, prostacyclin agonist, that's the PGI2. Commonest example, epoprostenol. In fact, it's part of the most efficacious therapy to use in group 1. Epoprostenol or Hyloprost, very easy to remember. Bosetan for the endothelin receptor antagonist, because endothelin 1 is very bad, it constricts it, so you have to oppose its action. Or you can give agent that allows CMP to accumulate and cause relaxation of the vessels. An example of what allows CMP accumulate is when you give phosphodiesterase inhibitors like sildenafil, tadalafil. So they are going to improve hemodynamics and increase exercise tolerance, and they will not be dyspneic with exercise. So don't forget, these are very applicable to people with group 1. Please, very important stuff. Yeah, and there's something they used to talk about, and that is vasoreactivity. But I think they are getting silent about it, and they are encouraging utilization of more of the prostanoids or the bosetan more now. Before they used to say that before you can administer any medication, particularly people with group 1, test their vasoreactivity. And how do you do that? You give them inhaled nitric oxide, and you do your right ventricular catheterization. So when you give them inhaled nitric oxide, you expect the pressure to drop by more than 10. So that shows that it is vasoreactive. So you want to give them the dihydropyridine calcium channel blockers. But now, just look at the stress. You are catheterizing, you are doing this. I beg, you too day on this thing for too long now. We just give them Nakam, Posetan or Poposterol, maybe they go out. So they don't talk about this anymore. Before they used to take this, the first thing you do, and if the person is not reactive, you do this. But right now, start this, and forget about this. Just have it at the back of your mind, because we don't know what those people can bring out. So
sorry, Dr. Ole, can you repeat that again? Just you test, you give them an inhaled nitric oxide, and you do what?
So you as you're applying that nitric oxide, you're already doing your right ventricular catheterization. So now you can measure the pressure in response to that stuff. You get it? So that is it. So group 4, thromboembolic disease. The definitive treatment is surgical thromboendarterectomy. You have to go in surgically and remove that clot. But you have to place all of them on anticoagulation too. They have to get anticoagulated alongside people with group 2 for the risk of AFib. So some people might not be fit for surgery. There are not new, interventions that have been talked about, like balloon pulmonary angioplasty. Just introduce like a small balloon into the through the vein up to the heart, then to the pulmonary vasculature to remove that clot. So it's a minimally invasive procedure, to help uh, remove the clot. So then we also talk about a drug which is Rosiguat. So this Rosiguat kind of facilitate expression of CGMP, which can help reduce pressure in people with recurrent thromboembolism. But I think it's still under all this clinical trial rating. So, but don't forget, whenever you see group 4, you guys do surgical throughput, and that's the only way you can be sure that that patient is going to be free from the problem. And definitely they have to be on anticoagulation too. So, I think we should stop here. Should we stop here?
So what you're saying is,
What did
for
you
group
call
4,
the drug again?
once you see patient in group 4, you just go ahead with the surgical maneuver.
Yes.
Do you
Yes.
need to do the medicals before that?
No.
Do you need
The only medical you are doing is anticoagulation.
okay for them?
Anticoagulation itself, no, if you solve the problem, you have to still remove what is there.
Either the surgery or the balloon angioplasty.
Yes, exactly.
Okay.
So maybe we should just quickly rush pulmonary thromboembolism. Are we still there, or everybody don't go out? Okay. Dr. Victor is raising up his hand. Okay. Don't know if you have a question. So pulmonary thromboembolism, I'll just quickly take it and know we have made progress. So pulmonary thromboembolism occur when you have occlusion of the pulmonary vasculature by a blood clot. So 95% of the emboli originate from DVT. So most of them follows DVT. So that's why you are scared of a DVT. And they can come from the femoral, they can come from the popliteal, they can even come from the iliac. But what I want us to know is that the higher up the clot, the more the tendency of PE. Most of them actually come down. They come from the down one, like maybe popliteal. But if anyone go arise from the iliac, otilon here, there's a very high tendency of it traveling to the lungs. So it can lead to pulmonary infarction due to ischemic necrosis, can lead to right heart failure, particularly when it's very massive, and eventually it can lead to hypoxemia because it's going to decrease surface area for gaseous exchange. So we have to familiarize ourselves with the virtual triad for DVT, which is venous stasis, endothelial injury, and hypercoagulability. I know we know all this. So venous stasis, anything if you allow fluid to stay for the veins. And the person is immobile, the person has done surgery, or the person is on mechanical ventilator for a long time, and the person is just lying on the bed, venous stasis. Or somebody has heart failure, particularly right-sided heart failure, or what do we call this? Somebody should remind me. This dual heart failure again. I think we have a name for it.
Is it congestive?
Yeah.
Just
Thank you, Dr. Roti. Congestive heart failure. So they can have venous stasis. Obesity. Obesity will put pressure on the vein and it will lead to venous stasis. Increased central venous renal failure. They have a lot of fluid retention too in them. Endothelial injury, just think of trauma. The only thing that can cause endothelial injury, aside recurrent DVT or previous one that happened, is trauma. Maybe a person fell, had a fracture, the person underwent surgery, endothelial injury. Then hypercoagulability, think about physiological conditions like pregnancy, because towards the ending month of pregnancy, you start seeing elevation of the fibrinogen. Although clotting factor falls, but all these fibrinogen, they come up. Reason is that the body is trying to adapt or prepare. God is trying to prepare the body for delivery so that the blood loss will not be too much. So fibrinogen goes up. And that will not really balance until like 6 weeks postpartum. So postpartum stage pregnancy, there are risk factor for hypercoagulability. Someone that had a lot of use of OCPs, they are highly thrombogenic, smokers, thrombogenic. coagulation disorders like protein C deficiency, protein S, factor 5 leading, antiphospholipid, all of them like that. Malignancy too, we already know this. Severe burn. Severe burn also increase expression of those clotting proteins, fibrinogen, everything is up in burn patients. So they have a very high tendency of throwing clots. So let us delete this guy that is here and go and focus on the modified Wells criteria. That's what we need. So someone that has a PE, how do they present? So you just see sudden onset. Once you see sudden onset dyspnea, PE should come to our mind. Sudden onset dyspnea in the question stem, PE, and the dyspnea with chest pain that is pleuritic. So pneumonia can cause pleuritic chest pain. PE can cause pleuritic chest pain, and there might be low-grade fever, from the inflammation that is associated with it. So it can cause cough, tachypnea, tachycardia, because tachypnea, they are dyspneic, they want to start breathing fast to take in air. Tachycardia, because of the obstruction of blood flow, and then eventually when it eventually leads to pulmonary infarction, you can see hemoptysis. That's very, very suggestive for eventual infarction of the lungs. When you see hemoptysis, it means that lung is already infarcted. So don't forget the commonest presentation, sudden onset dyspnea, that's it, with your pleuritic chest pain. Don't be carried away by the fever. Don't say, fever did this thing. It can't be PE. Please. They can have low grade fever because of their shared inflammation. So they can have cough too, tachypnea, tachycardia. So the symptoms that you need to look out for very well: sudden onset dyspnea, chest pain, tachypnea, tachycardia. Those are the stuff. Then the hemoptysis can happen due to pulmonary infarction. You can get history of immobility. That person has traveled for a long time, maybe from Nigeria to Australia, or the person has been bedbound for a long time after surgery. We are still going to talk about the Wells criteria, so we see all those things. So when you examine the chest, just like in someone that has pulmonary hypertension, we are going to have a loud P2. In addition to the loud P2 in pulmonary hypertension, what else do we get? What happens to the sound? Pulmonary
So
hypertension.
what's the question? In pulmonary hypertension.
Yeah,
Yeah, you have splitting.
So they will have a
Splitting.
paradoxical splitting.
Yeah. White splitting. Yeah.
They are going to have a white splitting. So they are not having a paradoxical splitting, they are having a white splitting. So, and they are going to have prominent A waves. They have prominent A waves. So this means that the right atrium is combating a lot of troubles with the right ventricle. It's trying to exert more force to, deliver its own content into the right ventricle. So that's why the A wave, because A wave is talking about atrial contraction, a wave. So pressure within the atrium. So it's very, very big. Prominent A wave on jugular venous cough, pressure cough. It's very classical too for somebody with pulmonary embolism. They have a loud P2, they have permanent A wave, particularly those with right heart failure. Then for massive one, you need to watch out for the two conditions. These two, you might not get RBB block, but if you see it's fine. It's good to know it. But these two is very common. So somebody having sudden onset dyspnea, sudden onset difficulty in breathing, pleuritic chest pain, tachypnea, tachycardia with cough. Now having hypotension and raised JVD, you can say confidently that is a massive pulmonary embolism, and you immediately need to thrombolize. That's not the time to give anticoagulant. You thrombolize to break up that clot. Very, very important because of the hemodynamic instability that you have seen. Raised JVP and hypotension. They will have new onset right bundle branch block because of the strain on the right ventricle. That sudden massive PE will not create escape route for the blood to leave the right ventricle. So the right ventricle starts stretching, big, like expanding, stretching on the bundle branches, and they can have a block. So what you are going to see, Dr. Babarinde is going to talk about it. Prolonged QRS, and you're going to see this typical RSR wave pattern, rabbit ear pattern on your ECG, particularly in the right glit, which is V1, V2. Dr. Babarinde is going to talk about it. So there's going to be prolonged Q wave RSR pattern. So how do you want to do your diagnosis? So the best initial test or the best initial step is for you to mentally calculate the modified Wells score, not the Wells score, but the modified Wells score, because they are different. So I have tried to create an acronym. It's not very easy getting one acronym, but I said Deep Pit Headmaster. I don't know if it makes any sense. So the first one is a D, which is the sign and symptom for DVT. You ignore the two E's. The next one is a P, which is talking about pulmonary embolism is most likely diagnosis. Deep pit headmaster. So, or the headmaster's deep pit. But the reason why I arrange this like this is so that we can place the numbers so that it doesn't scatter. Because the ones that are up are the ones that are taking larger numbers, which is 3. So, deep pit headmaster. So the D stands as symptom of DVT. Can you identify it in that patient? P, okay, does the patient have signs and symptoms of PE that you might consider as a diagnosis? Then the T is for the tachycardia. The I is for immobilization of 3 days or more, or surgery within the last 1 month. Then this P2 is like P square. So another P for previous pulmonary embolism or DVT. Then the last ones are the headmaster. Hemoptysis for the H, master for the malignancy. So the DP, which is the first DP, they take 3. Once you identify signs and symptoms of DVT, you give the person 3. Once you think that you are also seeing additional features of PE, you give the person 3. So that's 6. So definitely someone that has 6 above needs to get no, is above 6. Someone that has above 6 needs to get urgent treatment without investigation. We are going to talk about it. Then the next P, which is a previous DVT or PE, the high immobilization or surgery, and the T for the tachycardia, heart rate greater than 100. Heart rate greater than 100. So the tachycardia, the immobilization, and the previous PE or DVT, the PIT, they are taking 1.5 each, while the last one, which is the headmaster, is taking 1.1. So DP 3.3, PIT 1.5, and the HM headmaster 1.1. So you have a simplified clinical probability assessment. So the simplified one is just to quickly know what investigation you are going to do next. So once it is greater than 4, you do your CT pulmonary angiography. But once it is less than 4 or equal to 4, so we have to know equal to is very important. Some people, that's where they get confused. They're like, is it greater than or equal to 4 or less than or equal to 4? It is less than or equal to 4. So once somebody has 4 or less, you have to do your D-dimer to rule out DVT. But if the person has 4 or more, you don't need to do D-dimer. You just go straight to your CT pulmonary angiography. I will talk about where we need the traditional one. So just let us know the traditional one too. If somebody has greater than 6, if all our values, we got a value greater than 6, in fact, prophylactically, you might not even need to be doing CT stuff. Give the person anticoagulants. If it's moderate, okay, or low, that's when you cannot be thinking, okay, let me do investigation first. So let us go to the best initial test depending on the Wells score. So if the modified Wells score is less than or equal to 4, the best initial test is a D-dimer test. Very, very important stuff. You do a D-dimer to rule out your PE. It has a very high negative predictive value and sensitivity. So I think we need to know this information too. That's a high negative predictive value. But it's not specific because there are so many things that can cause elevated D-dimer that is not PE. Someone can be pregnant, someone can have malignancy, and the person will have elevated D-dimer and they don't have PE. So it's not specific. But once you get a value more than or equal to 500, then you need to go on with your investigation. By doing a CT scan, a CT angiography of the chest with contrast, a CT scan of the chest with contrast, to look at that chest. So, but if for any reason you can't give that person contrast because the person is pregnant, because the person is having renal failure, because you need to excrete the contrast through the kidneys, and you cannot give, or the person has contrast allergy, you might want to do your VQ scan, your ventilation perfusion scan, to look at the evidence of VQ mismatch. And we know that the VQ mismatch we are going to be expecting in someone with P is high VQ mismatch. True or false? High VQ ratio. True or false?
True.
Nice. So it's going to be true because your Q is going to reduce and your V is going to be the same. So that ratio is going to be high. Very important. So if you have a normal D-dimer, you can safely say that, okay, what you are dealing with is not P, so you don't need to go further. And the cutoff point is 500. So I get a patient that has well score I calculated to be 4 or less. I do my D-dimer. If it's more than 500, I go on my CT. If it's less than 500, I stop. But if your well score that you have calculated ab initio is more than 4, 5 onwards, you start with your CT scan of the chest. It has a very high sensitivity and high specificity. So
Sorry, Dr. Bole, what did you say about that? If your D-dimer is less than 500?
yes, D-dimer is less than 500. You don't continue with the CT. You have ruled out DVT because it has high sensitivity and a high negative value. So
Okay, so if it's greater, you go ahead with the CT.
With the CT, exactly.
If it is 500.
Yeah, 500 or equal to 500. Both of
Okay,
them.
you go
Go ahead. Yes. So this is the CT showing the pulmonary embolism. You can see here. This is a bifurcation. So you can see the filling defect here, and here. So this is a thrombus, in the pulmonary vessel. So you can do your VQ mismatch usually in people that have contraindication to CT with contrast, because you need to use contrast. This is not NODU. That you cannot use all those. Sorry. So you need to use a contrast when you're investigating this person. So anybody that has contrast allergy, you might not be able to use CT. So you will use your ventilation perfusion scan, which we have talked about, and you know that the ratio is expected to be high in someone that has P because of reduction in the Q, which is the perfusion. So they usually grade the VQ mismatch to, depending on the value, into low, intermediate, and high. Then if you do your arterial blood gas, the picture you expect is respiratory alkalosis, because the person is going to have tachypnea, hyperventilation, bring down CO2, but because of the fact that there's already a clot, even if the person hyperventilate from now till tomorrow, it will not still increase the oxygen. So oxygen will still be less than 80. So if you do your chest X-ray, it might show a normal appearance, or you might see atelectasis. So the reason why you can see atelectasis in a patient with PE is because the embolism is going to reduce delivery of blood to the lungs, and you need blood and its component to form surfactants. So surfactant is going to be reduced, surface tension is going to be high, leading to eventual collapse. Pleural effusion is going to happen, and we are going to talk about pleural effusion proper, and the type of effusion that typically happens in them is exudative pleural effusion. Because that condition is going to generate a lot of inflammatory cytokines. Yeah, that is going to penetrate the vessels and lead to extravasation of fluid into the pleural cavity. So don't forget, the type of pleural effusion you typically see commonly in people with PE is exudative, although they say it can cause both. Yeah, but the commoner one is exudative type. And there's stuff for people, for some of us that like stuff, because I know that Dr. Antonia likes dropping the big names. When Dr. Kenneth ask, what name is that? Dr. Antonia is talking about lamb, talking about, so Hampton hump is another big name if you want to learn it. This is wedge shape infarct. So people with very large PE, they can have this wedge shape infarct, because one thing, the reason why it's wedge shape is that anytime you have infarct in the lungs, it usually takes this wedge shape pattern, because that's the way the lungs is kind of containing loose connective tissue. So the way the infarct looks like in the lungs is wedge shape. So that's what you call the Hampton hump. The Westermarck sign, is talking about focal oligemial or collapse of the vessel distal to the pulmonary embolism, because once there's embolism, blood will not be able to flow downstream. So all the vessels downstream are going to collapse, or blood flow to the area is going to reduce. So you call that the Westermarck sign. So you are going to notice that there will be like, paleness of the vessels that are distal to that, embolus site on your X-ray, Westermarck. Area of infarct, Hampton. Maybe we'll look at X-ray. I never even thought of putting up the stuff. Maybe I'll look for one now. I will check. So ECG, commonest finding ECG in people with PE is sinus tachycardia. But you can also see the classic triad of, I think it's about 25 to 20% of people. That's when you see the classic triad of X1, Q3, T3 presentation. So you see your S wave big in your V1, your lead one rather, not V1, your lead one. Then lead 3 is going to show Q wave and T wave inversion. So you're going to see inverted T wave, a big Q wave both in lead 3, and a big negative deflection of S wave in lead 1. ECG finding. Classic triad. I think we call that, is it a margin white sign now? Yeah, I can't remember. So, it's a triad of pulmonary embolism. Then you can also do lower extremity venous ultrasound to rule out your DVT. Might not be necessary at the end of the day. So let's go to so dyspnea tachycardia and a patient with normal chest X-ray, because we have said it that in some of them you can have the X-ray to be normal. So X-ray is not really the major investigative tool, but you see sudden onset dyspnea tachycardia in someone that has been hospitalized for a long time or bedridden for a long time, you should have a high suspicion for pulmonary embolism. So how do you treat? The treatment is anticoagulation, except in massive pulmonary embolism that you have to thrombolize. So what you do is that you first evaluate, okay, I think I need to anticoagulate this guy. Does this guy even have any contraindication to anticoagulation? Maybe the person had previous hemorrhagic stroke, some coagulopathy, recent surgery, recent gastrointestinal bleeding. You might not want to anticoagulate there. So you might want to do something else. Or if the person has no contraindication to anticoagulation, then you continue with your investigation. So what you do is that you calculate your West score. So what are you getting? What are you getting? We already know that if we are getting 4, any value more than 4, we are definitely going to do our CT with contrast. If it's less than 4, you are going to do your DVT. But that's good. That's very good. But depending on the score you get specifically.
Sorry, Baba, well, I lost my network. I beg, I missed out.
I think, okay. I thought he was asking about DVT, D-dimer.
No,
Okay.
I'm not asking about D-dimer. I lost this network. I lost my network.
Okay, so what I was saying was, once you
Contraindication.
Yes, contraindication. So once you have ruled out that there's no contraindication to anticoagulation, you try to, do your modified well scoring. Then you have your values with you. Now, if you have value of more than 4, definitely, even if you are going to investigate, it's going to be straight to CT. If it's less than or equal to 4, you know that if you are going to investigate first, it's going to be a D-dimer test. But now, if you get a value of 7, because why? Because the patient had history of left of leg swelling, redness, calf pain, and the person develops sudden onset difficulty in breathing and pleuritic chest pain, and the person had hemoptysis, or the person had history of malignancy. That's like 331. That's 7. So in that kind of person, you know that you have a very high suspicion according to um the the first assessment, which is the traditional clinical probability. Person at 7, that is high. You don't wait and be doing CT scan. You immediately anticoagulate that person on an empiric basis. Then you now continue with your investigation. You now continue with your investigation. But say you don't anticoagulate them down. But if you got a value of let's say 6 or 5, then you can now start looking at greater than 4, less than 4. If you have a value of 5, that's greater than 4, so that's going to be CT. If you have a value of 3, that's less than 4, that's going to be D-dimer. So that's going to now guide what we are going to do in this pathway. Please, I don't know if I make sense, or I should come again with what I've said.
You are making sense.
Okay, so once let's say the person, you got a value of 3, you know that your next diagnostic evaluation is going to be a D-dimer. You do your D-dimer. If your D-dimer is more than 500, you go to your CT, and whatever you find there, if you have your clot, if you have not anticoagulated, you start your anticoagulation. That's it. Provided that all your investigation is not more than 4 hours. If you are still investigating out more than 4 hours, you have to start anticoagulation empirically. If you never see waiting you define within 4 hours, start it. So once it's moderate or low, like for example, it is like maybe 3 is DVT. If it's like 5 is not still high, so it's going to be in this category, but 5 will warrant CT. So you do your CT, you check if it's there. If it's there, you start anticoagulation. If it's not there and you have started again, maybe it's because it's more than 4 hours, you stop it. Simple. But it changes for people with contraindication to anticoagulation. So if you have established the fact that this person has contraindication, the best thing if you give them is IVC filter. That is what we can use at the end of the day. We cannot anticoagulate someone that has contraindication to anticoagulation. So we now start our finding. So okay, we have identified that this person has contraindication. So what is our West score? The West score is
And 6.
yeah. So if it's let's say like 3, you do your DVT, blah 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 blah. You go to your CT, then you do your IVC filter. But if it's more than 4, let's say 5, you can do your CT. But if it's more than 6, like 7, and you know that you have a very high suspicion, you can do your IVC filter. So
But for contraindicated cases, right?
yes, for contraindicated cases for anticoagulation, the best you can do for them is IVC filter. You cannot do anything else. But don't forget, so the contraindications, these are the contraindications. So someone that has recent surgery, hemorrhagic stroke, active bleeding, particularly GI, active bleeding, aortic dissection. You can't even be talking about doing anything. So that's that. So if diagnostic evaluation cannot be completed within 4 hours, you start your empiric anticoagulation. Very, very important stuff. Now, this person we have investigated, we have seen the P. What do we do? Acutely, we start our anticoagulant. So unfractionated heparin, you can use your low molecular weight enoxaparin, you can use fondaparinux, you can use your DUAX, rivaroxaban, apixaban. But we should know that apixaban is a very good guy. Apixaban is very excellent because apixaban can work well in people with renal issues. So you can use it long term. because it's not dependent on renal stuff, and you can even use it for people with renal problem. So in patients with high probability for pulmonary embolism, you have to give your anticoagulation before confirmatory testing. We have said this. And what's the value for our higher probability? Anybody wants to remind us?
High
Value
probability of
500, is it?
More than 6.
Or what are you talking about?
No.
are you
Value
talking
for
about the 6
higher
or what?
probability. Yeah.
For what?
For P.
Six.
More than 6.
More than
Eh?
6.
Greater than 4.
More than no.
More
Higher
than
More
probability
than
for what?
6.
For
More than
More
6.
than
biology.
6.
yeah.
More than 6. That's the
More
high
than 6.
probability.
Or what is that, please? I didn't hear.
Like I said, what value is the value for high probability for P?
Oh, okay.
More than 6.
Okay, greater than 6.
That's when
Yes.
you start your anticoagulation immediately.
Yes.
So your investigation must be within 4 hours. Once it's taking more than 4 hours, you go ahead with anticoagulant.
You give the anticoagulant straight. So people with renal failure, unfractionated heparin, and apixaban can be used. You cannot use low molecular weight in renal failure. Hope we know that already. So for chronic cases, you because for chronic you might need to anticoagulate them for a long time. So you cannot use unfractionated heparin. Who knows why? I think it's something we know. We cannot use heparin for a long time because of that stuff. Anybody knows? From
Is
hematology
it
step
him?
1.
What are you asking of? Sorry, Dr. Wale.
Like if for chronic treatment you are not going to use unfractionated heparin.
Because of
it, yes, because of it, particularly the type 2 one.
type 2.
So you are not going to use unfractionated because of it. So you prefer to use low molecular weight and the DUAX or warfarin. But warfarin, you should be careful about using warfarin in people that are pregnant, because of teratogenicity. We already know the indication for IVC filter. Anybody that has contraindication to anticoagulation takes IVC filter. Or you have used therapy up to the maximum. You have given therapeutic doses of anticoagulation. The person is still experiencing recurrent thromboembolism. You need to give them IVC filter. So those are the two conditions where you have to use IVC filter. Either the person is not responding to medical optimal dosing, or
Contraindicated.
or what?
Or it is
All those
anticoagulant.
for contraindication of recurrent surgery, then active bleeding, and co.
Exactly.
That's a contraindication of anticoagulants in them.
Yes. So then
Sorry, Dr. Bawale, can you help me with the why warfarin is contraindicated in pregnancy? I can't remember again.
I think teratogenic.
teratogenicity.
Oh yeah.
All these stipple epiphysis,
Yeah, stippled epiphysis.
Epiphysis, yeah.
thrombolysis, very important for massive pulmonary embolism. And then what do we say we are going to watch out for massive pulmonary embolism? Everyone wants to remind us. What are the two clinchers we want to look out for?
Hypertension and JVP.
Hypertension and JVP. So hemodynamic instability generally, hypertension and JVP, and we can also see the right RBB. DVT prophylaxis is essential for all immobile treatment. For all immobile patients, you need to give them. The best thing to do to prevent DVT is to embolate them early. That's the most effective. Or you place them on drugs, which is heparin or low molecular weight heparin, subcutaneous heparin or molecular weight heparin. Or you use compression stocking, but that's not, very excellent. So the best is tell them to walk around the hospital. Give them drugs, heparin, or compression stockings. So we come to the end of our lecture for today. Let me see if there is anything else that we can have a look at to just see.
How soon are we going to have this your video so that we'll go through it?
Yeah, so the problem now is that we have to send it to our IT people. It's no longer in our control. Once I upload, we send it to our IT, but definitely it will be there in the by let's say by I don't know, maybe before afternoon tomorrow. So let's just look at this. Um, a 56-year-old obese man comes to the emergency department complaining of acute shortness of breath. He twisted his ankle 5 days ago and had limited mobility since. Other medical problems include type 2 DM, hypertension, CKD, right knee osteoarthritis. His medication includes insulin, amlodipine, and low-dose aspirin. BP is 160, pulse is 110, hemoglobin is 11.2, platelet count is 230,000. Estimated GFR is 20 mils per minute. Ventilation perfusion scan shows a right upper lobe perfusion defect with good ventilation. Which of the following is the best initial treatment for this patient?
Yes, renal issues now. So we should be looking at unfactorated heparin.
Unfractionated heparin. So the option is enoxaparin, fondaparinux,
Mm.
rivaroxaban, unfractionated heparin, warfarin. So unfractionated heparin is correct.
Or apixaban.
Yeah. Or apixaban. Thank you, Dr. Joy. So particularly when the GFR is less than 30, you have to consider that. Okay. The answer
Is it
B.
greater than or lesser than, Abi?
Less than.
Okay.
Like so. Why the answer there? Why did I put the answer? Okay. So a 69-year-old man undergoes urgent laparotomy due to strangulated inguinal hernia, necessitating resection of 40 centimeters of small bowel. On the morning of the fourth operative day, he falls while getting out of bed. Afterwards, the patient is responsive but confused. His speech is incoherent and he cannot remember what happened. The BP is 83/55, pulse is 130, respiration 28. Fingal oxygen saturation cannot be obtained due to thready pulse. Examination shows diminished breath sound at the lung bases. The neck veins appear distended. Abdomen is soft and non-distended. The surgical site is unremarkable. ECG shows sinus tachycardia, a new right bundle branch block, non-specific T-wave changes. Immediate resuscitation with wide open IV fluid is ineffective. Shortly after, the patient pupil began to dilate, his pulse decreased to 35, and he became unresponsive. He eventually dies despite resuscitative efforts. Which of the following is the most likely cause of this patient death?
Massive pain.
Pulmonary embolism.
Massive.
Massive embolism.
Yeah, massive pain.
Yes,
Actually,
massive. On the fourth day post-operative. So maybe he has been on bed, for a
Mhm.
long time. And then we also saw the features of hemodynamic instability, hypotension. We can see the tachycardia, and we can
And
see the fact that it's a
right
right-sided
bundle
stop
block.
because the neck veins were distended. Yeah, and we can see the
Mhm.
ECG findings of
the right,
corroborating
the three of them.
they are there. So P is correct. A 53-year-old woman is brought to the emergency department after she collapsed suddenly while standing and lost consciousness for approximately 3 minutes. She recovered spontaneously, but she was very weak and dyspneic. She also reported left-sided chest pain. There was no tonic-clonic activity or incontinence. The patient was recently diagnosed with colon cancer on a routine colonoscopy and scheduled to undergo surgical resection. Her only medical problem is hypertension, but she has not been compliant with her medication. Her blood pressure is 86/50, pulse is 120 and regular. Pulse oximetry shows 80% on room air. She is diaphoretic and tachypneic. Jugular venous pressure is 13 centimeters of water. Lungs are clear to auscultation. Further workup of this patient will likely show which of the following.
Is she going to have
The
right
right
ventricular
branch.
dysfunction, right?
That is very correct.
Mm-hmm.
So
Mhm.
there's going to be right ventricular dysfunction because this is pointing towards massive pulmonary embolism too that this patient has developed. So
Yeah.
we can see the chest pain might be due to the hypertension. So that's is like a distraction. So this left chest pain is due to the hypertension, the left ventricular hypertrophy, but the fact that she has hypotension and raised JVP,
Mm-hmm.
That's like, and because she has been standing, Abby,
Yeah.
was standing for, so she could have thrown a clot or something from there. So that can explain that presentation. She had a massive pulmonary embolism, and that can be associated with right ventricular dysfunction. So that is that. All right. So
Dr. Mbabala, with the first question, can you
yes,
that first question with the options?
yeah.
You have about four of those medications there that you can
Mhm.
use in case. You have the unfractionated, you have the rivaroxaban, you have the fondaparinux. They say you can use oral fondaparinux, and then that's it. They don't enoxaparin is not there. So
Enoxaparin, yeah, enoxaparin is low molecular weight heparin, right?
okay, yes, almost all of them is there. So the unfractionated is chosen because the patient has a renal issue
Exactly. That was why. That's the only reason.
or
Yeah, I know
apixaban.
that you don't use warfarin in acute. You know,
Mhm.
hmm
Mm.
you don't use warfarin in
You have
acute.
So
to do your best.
the unfractionated and the apixaban are good for renal impairments, those with renal
Yes.
impairment.
Yeah.
But you can also give rivaroxaban or oral fondaparinux too in acute phase.
Exactly. In the presence
Okay.
of renal competence. So
In the presence of renal competence. Okay.
okay. I'm not. Let me see. I don't think I have any more questions. Oh, something there. Okay. Talking about the gram, still more. So I'll try and be delineating those things with separate colors so that it's going to be easy for everybody. A 69-year-old man comes to the office due to 2 days of increasing shortness of breath and lower extremity edema. He drinks a half of vodka daily and 45 pack year smoking history. There is no past history of hypertension or ischemic disease. The patient has sedentary lifestyle due to disability from a work injury at the age of 20. He takes no medication and he has not seen a physician in 20 years. The BP is 130/90, the pulse is 90, oxygen saturation is 90. Cardiac examination shows faint heart sounds. Jugular venous pressure is 11. Lung auscultation shows decreased bed sounds. Liver span is 18. Ascites is present. There's bilateral 3+ lower extremity pitting edema to the knees. Chest X-ray reviews enlarged central pulmonary arteries without evidence of vascular congestion. Which of the following is the most likely diagnosis?
I wasn't following, sir. What's 6% about?
What did you say?
Shortness
I
of
didn't follow this
The
question.
jugular venous pressure is high in this
2
patient.
days increasing shortness of breath, cough, and lower extremity edema.
hypertension, but I need to know why. 1 minute, Dr. Babawale. Yes,
Jugular venous pressure is elevated.
yeah, it's pulmonary hypertension due to
Is that it can why can't it be secondary because of ischemic heart disease? Okay, there is no past history. Okay.
this pulmonary
Yeah.
hypertension.
Pulmonary.
Fantastic.
This.
Yeah.
Of course, I know that all of us we have gotten the answer already. I mean,
It's
Mhm.
called
it's called pulmonary.
Yeah. Pulmonary hypertension.
So it could be from anything. This man is smoking. We don't know if he had maybe COPD or something, or it is actually idiopathic. We might not necessarily pick the cause because they didn't give us more detail into that. They just told us that the man smokes, and this
Yeah.
45 pack here is very, very significant.
Mhm.
So What else again is there? I think that's the only thing. The other ones are
Yeah, it's the only one that has like the lung pathology out of all of them.
and I forgot the commonest cause of pulmonary hypertension in the US is COPD. So the commonest cause of pulmonary hypertension in the US is from COPD. So definitely that's why they are trying to paint it like this. 45 smoking years. So most likely had a COPD, that developed into the pulmonary hypertension and had a right-sided heart failure. So that's why he's having all this edema everywhere, the liver span enlarged, and we should not forget this X-ray finding. It's kind of helps us in this setting, revealing enlarged central pulmonary arteries without evidence of pulmonary congestion. So this rules out a type 2 problem. We can see. So definitely we know that we are likely dealing with anything outside type 2 because there's no evidence of vascular congestion. Can we see that? So pulmonary is the answer. And we should not forget COPD is the most common cause. But I don't think they are going to ask that, So that can just help us link this answer to a likely cause. So we are going to say,
Okay. Dr. Bawale, sorry. So, like this thing you highlighted now. So what you're saying in essence is that because we don't have evidence of that vascular congestion, so that shows that the pathology is not from the left, that is now going back to the right side, right?
Exactly. If PCWP is less than 15, if PCWP is more than 15, then it's likely to be from left. But if it's less than 15, it's not likely to be from left. If it's less than 15, or you are not seeing any evidence of vascular congestion, you can say that this is not the left. Because in the left, you are going to see vascular congestion. But that doesn't still change the answer. That's still pulmonary, So I think that is that. So we'll continue. Still have a long way to go.
Yeah, so that's a long one. But it's better we understand it now as we go because it makes reading easier.
Yeah. We can just try to look through our U-word for the ones that we're testing ability to calculate the West score. Like we need to know, so that we'll be able to calculate the West score ourselves. That we look at what those. Does it have a DVT? Does it have PE signs, hemoptysis, malignancy, tachycardia, past history of DVT or PE, any history of immobility? Then we calculate our score and we know what next to do. So, all right. Do we have any question? Any question?
No, at all. Thank you so
Thank you
much.
so much.
Okay. Come to the end of today's lecture.